Please take your seats. The program will begin shortly. Please take your seats. The program will begin shortly. Welcome to Politico's Healthcare Summit. Please welcome Politico's executive producer of events, Annie Allen.
Thank you. Good morning. Thank you for being here. We're thrilled. I always feel like when we're hosting these events, I get a little nervous. Like we send out all these invites and nobody's going to come to our party. So I'm really grateful that you all are here today. We have a big day. Our programming is going to run from about 8 to 1 today. So I hope you all can settle in. We have lots of food. We have snacks. We have a break in the middle. So, I hope that you all are committed to being here and hearing the full breadth of the conversations we have. I want to talk a little bit quickly at the top of this about our healthcare team. For those of you, I'm assuming many of you here subscribe. How about this? Let's do a show of hands. How many of you subscribe and read our healthcare content and newsletters? Eli Reyes, I hope you are seeing this wherever you are. That is amazing. So then you all know that our healthcare team offers in-depth and dynamic coverage in the politics and policy of healthcare, covering federal agencies, Congress's committees of jurisdiction, medical associations, AI in healthcare, and lobbying. We have 4 newsletters: Pulse, Future Pulse, at Healthcare PM Pro, Future Pulse, and then Healthcare PM Pro, Prescription Pulse also, which appears twice a week. I want to take a quick second here, too, to thank our sponsors, PCMA, the Joint Commission, Walgreens, Adtalem, and Hackensack. Thank you all for being here and being our partners today. We couldn't do this without you. And first up, I would like to, for our first conversation this morning, my colleague, the Capitol Hill Bureau Chief and Senior Washington columnist for Politico, Rachel Bade, is going to be joined in conversation with Congressman Vern Buchanan, the chair of the House Subcommittee on the House Ways and Means Committee. Thank you all for being here, and stay tuned.
All right. Hello, everyone. I'm Rachel Bade, Politico's Capitol Bureau Chief, and I'm joined today by Florida Congressman Vern Buchanan. Thank you so much, Congressman, for being here. The Congressman currently serves on the House Ways and Means Committee. He has for a while now. How many years did you tell me just back in the green room?
Too many, but 14 years
14.
On that committee, but it's my 10th term.
Currently, he oversees the Health Subcommittee, so obviously a big player in the area we're going to talk about today. And he also co-founded the Make America Healthy Again caucus in the House, so we're going to talk about that too. And by the way, back in the green room just now, he was ribbing us for the unhealthy, sugary snacks that were in the green room. So already starting his advocacy here. But before we get to healthcare, let's start with a little bit of news from last night. You're obviously a Florida Republican. Last night, Republicans in your state did win, as sort of was expected, 2 special elections to replace Matt Gaetz and Mike Waltz, but they were closer margins than I think a lot of Republicans would like to see. What's your sort of takeaway from last night?
The one in Jacksonville, we felt pretty good initially on that because it had a lot to overcome. It's an R plus 20 or something. But the one in Melbourne, some of the polling had it at one point, could have gone either way. We brought in a lot more resources, whatever that was. But originally, he had raised about $1 million, and the candidate, the race got nationalized, so it ended up with another $10 million on his side. So we thought it'd be a tougher race than it was.
Well, it's interesting. One of those races was like 30. President Trump won it by like 30 points,
yeah.
And now it's 10 points a piece on each of those districts.
Yeah.
Are there any things that Republicans need to sort of internalize, any lessons, you think? Or do you think this was a purely like, the money piece that was talking here?
It makes a big difference. It's a part of the Orlando TV market. So when you're talking about 1 million and 10 million, it grabs your attention. So there was a bunch of different things. I wasn't as active in that race, maybe wrote a check, but short of that was focused on what's going on here in Washington for the most part. But that was a big issue. It was a very big concern to a lot of us. I chair the delegation in Florida, and so all of us were a little bit nervous about it at one point. But then the numbers started moving in our direction. It's all about turnout in these little, these smaller races terms of that.
And I'm sure Speaker Johnson is happy today with that margin and not losing those seats. So let's talk about MAHA. Why did you decide to create the House MAHA caucus? Tell us about your decision to do that, and what do you want to do with it?
Well, their focus is on diet and exercise and some other things. And my experience we all have our own life experience. I was in business for 30 years and other things, but you deal with your weight over the years. And one diet that came up changed my life for the last 20 years. I lost 30 pounds, kept it off, and don't have to think about it as much. Someone had wrote a book, and there was an equation in the book. And on the top of the equation was nutritional value of the food. And on the bottom of the equation was calories. So what is the most nutritional food with the fewest calories? And you can eat all you want. Now, obviously, it's a lot as it relates to vegetables and stuff like that and fruit. But that changed my life. And then my grandkids, we have 10 grandkids, 10 and under, they'll say, Papa, you can't eat that or you can't eat this. But I told them I got a 20% where I'm more open-minded in what I'm eating, or not as careful on that, but I try to be more scientific. And that's made a big difference to me just on weight management and everything else. And I could take that off the plate. And you can eat all you want. You just got to eat the right things.
So I could have a donut for lunch, but then I got to skip
But that's on the
dinner
20%, yeah.
But no, really, what is Congress's role here? I mean, we talk about nutrition. These are very personalized choices. What do you envision your caucus actually doing?
Well, think about it this way. We're spending $4.4 trillion on health care. Right now. And Medicare just alone, I think it's $1 trillion, 1 or 2, and it's getting worse. So we're spending more money, and the results from what we're spending is getting less. So we have to play a role in this space, because if you take a look at Social Security and Medicare, it makes up 1/3 of the budget. When you're taking in last year, we took in, and this is the bigger picture that as a business guy I try to look at. When you take in $5 trillion in terms of receipts and you spend $7 trillion, that's got to end. When I came to Congress, don't blame me, but it was $8 trillion. Today it's $37 trillion.
What'd you do?
But my point is we've got to change that. My first week in Congress, I introduced the balanced budget amendment in every new Congress since. But we need to get serious about and deal with that, because at some point it's not a matter if, it's when it becomes even a much bigger problem.
So it's interesting, because back in the day when I first started reporting, back in Obama's first term, Republicans sort of, went bonkers on the Obama administration, on Democrats for trying to promote, at times, healthy choices. I remember some Republicans saying Democrats were trying to demonize sugary snacks at the time when grocery prices were high. I remember Republicans sort of mocking Michelle Obama's Let's Move campaign about combating childhood obesity. And just Republicans sort of attacking, mayors, governors, Democratic governors who wanted to sort of limit access to sugary soft drinks. Were Republicans wrong back then? Or can you just talk to me about what is the genesis of, the Republican Party now being the one carrying the MAHA sort of mantle? Like,
I think
what happened in 10 years?
I've been focused for the last couple of years on this MAHA before it became MAHA, in a sense, because if you look at their 4 principles. But I think the big part of it is it's new leadership, and people are looking at things differently. I'm clearly looking at things differently, because we can't continue down that road. You mentioned the obesity factor. Well, children, 20% obese today. Used to be 3 or 4 or 5%. If you take a look at adults, 40-45% obesity. This leads, as you know, to type 2 diabetics. In terms of the military, we can't get a lot of the kids, 31% don't qualify because of obesity. So there's a lot of things we've got to change and look in a different direction. And I think that change comes. And we all hear about over the years diet and exercise, but diet is the key in terms of what you're putting in your system. You need good fuel. That makes a big difference. And then you need to move. Someone said, go for a walk 2 miles 5 days a week, and I'll take you off a lot of that medication you're on. So there's a lot more we can do in that space, and we got to encourage and educate. And not everybody's going to do it, but we'd like to see more people step up and make a difference. I know businesses are doing more in that lane. They're building fitness centers. I didn't see as much of that before, but I'm associated with businesses, and a lot of them are going that way. But we have to all work together. My big picture is, you've got to be the CEO of your own health. You can't just count on outside services. The way we react, in terms of the way we pay people too, the whole idea of paying doctors and everybody else, fee for service, that's got to be looked at. It's the wrong incentive.
Do you think, is it a matter of Congress sort of writing legislation to incentivize this behavior via some sort of tax incentives or funding for schools if they promote X, Y, and Z healthy things? Like, how do you envision writing policy to actually prescribe and to encourage people in a certain direction?
You make a good point. It's all about the incentives. And as a business person, one of the most powerful tools I had working with my managers and different people was getting the incentive right. And I think you got to question the incentive in terms of fee for service. I think it creates the wrong incentive. And so I think we have to take a look at other opportunities in terms of setting up a structure and everything. But that's something I want to work on, and we're going to work together. I had a chance to meet with the Secretary Palm Beach maybe a month or two ago, and then this past week, and we had a good discussion, and we're both moving down, I think, parallel together, working together in a lot of this. There's a lot more we're going to do. He's going to get out more. I've asked him to come to Florida, and he's accepted to do that. So we're trying to work through some of those details. But the idea is, we've got to find a way to bring down the cost, and a lot of the cost is tied to chronic diseases. I think 80–90%. I just personally believe we could eliminate a lot of chronic diseases through a better diet and movement. I think it would make a big difference.
So we have to talk about Medicaid right now because obviously Republicans are in this sort of position on Capitol Hill trying to move President Trump's legislative agenda. Big question right now is what happens with Medicaid. We've heard Democrats suggest that Republicans are going to cut the program in reconciliation. I know Republicans have said they are not going to do this, but your colleagues in the instructions for reconciliation did prescribe $880 billion worth of cuts that perhaps might come from this program, Medicaid. What cuts do you think Republicans will make there?
They're looking at it, but I can just tell you, I'm not for cuts in Medicaid. It's people at most risk, children and families and single moms and stuff like that. So, I'm going to do everything to make sure it doesn't go down the road. But I can tell you, being here, there's a lot of inefficiencies. We've got to find a way to be able to trim a lot of the costs down, do things better for less. And I think in a lot of it, we got to get the diet right with a lot of these, especially on the Medicaid, with especially kids, as I mentioned, 20% obesity. So there's a lot of work to be done. And I think the president's made it pretty clear in terms of Medicare and Medicaid, and that does impact my district. I have the 5th oldest district in the country, but it impacts a lot of districts. We want to keep that viable.
What about work requirements on Medicaid? Is that something you would support?
Ideally where you can, but if you're talking about single moms with 3 kids, I don't know how that works. But the bottom line is that's something some people feel strong about. I think you got to look at based on the situation.
What about reimbursement rates for Obamacare Medicaid expansion? Do you think that is something Republicans will touch?
I think it's something they're going to look at. That's just my feeling that we haven't got there on that discussion, but I think that's something they're going to clearly look at.
And you support that, then, finding savings from the Medicaid expansion?
Yeah, Medicaid, Medicare, Social Security, I'm for all of that because what we're doing now isn't working. You can't continue to spend trillion. Our interest on the debt's $1 trillion a year. So you've got to take the first trillion of taxpayer money and pay the interest on the debt. It's got to change, and we've got to find a way to do that where we're more efficient on delivering these systems. I can just tell you, there's always been a feeling like on Medicare, for example, that there's at least 10% fraud or mismanagement or whatever. That's been clear. Everybody kind of agrees on that. And those types of things have got to get addressed. And we haven't done it. And, you're talking, hundreds of billions of dollars.
Easier said than done.
Yeah, it's not easy.
Yeah. So speaking of, we were just talking about the Obamacare Medicaid expansion. One of the sort of most underreported healthcare stories this year is actually the expiring Obamacare cost-sharing subsidies that end later this year. For people who are not familiar, those subsidies are for oftentimes middle-income earners who the original Obamacare law did not necessarily help or address. They're often self-employed, small business owners who make a decent income, but when it comes to buying your whole
Yeah.
family's health insurance,
Yeah.
that's much more difficult. We are now seeing a broad swath of the industry, like hospitals, insurers, run ad campaigns asking Congress to extend those subsidies. Do you think that Congress should do that?
We're going to be looking at everything. We're in this process right now in terms of taxes, but also in health care. And we're just looking at the whole package. There's going to be some things that'll be, trimmed, however you want to look at that, especially where there's waste and inefficiency. And then there'll be some things that might be added to in terms of programs. So I can't tell you because nobody knows yet. These are things we're working on. I'm going to go to a meeting now for 7 hours. We're going to talk about like taxes, which is it is a reality we got to deal with because of 2017. So all that's expiring this year. So we're going to spend a lot of time about what's going to get in the basket and what's going to have to come out.
I was going to say, I don't think I've heard people talk about the subsidies, the Obamacare subsidies, in terms of this reconciliation package, right? You guys aren't talking about doing it now. It would have to be a later.
Yeah, that's my sense of it, too.
And is there a belief that there's fraud there that you guys think you can go after?
I just think we need to find a way to look at any way we can do things better for less. And I can just tell you, I've had a lot of friends that tell me every 4 or 5 years they would just purposely, even if it wasn't a problem, blow up an organization so they can go and redial it in. Because there's just a lot of stuff that creeps in where people are not as productive as they were originally, and we just got to find a way to be more efficient and do with less for more.
Last question on the Medicaid, the Obamacare subsidies. That would likely have to be something you work with Democrats on, right? Or do you see Republicans being able to do that themselves?
I think most people know me. I'm probably one of the most bipartisan members up here, and that's my record. And so when I work with my colleagues that are Democrats, I try to find a way to get to yes. That's my mindset. They bring me something. They know to bring it to me as a senior member on Ways and Means. I try to figure out how to get to yes where it makes sense. Some people don't like that, but that's the mindset I bring to it. I want to fix things as a business guy, and one way to fix them, the majority of the time, is working with your Democratic colleagues. And they've got good ideas, too, but we need to figure out a way, especially in terms of this debt and deficit, that we work together. So that's kind of where I'm at.
You mentioned a 7-hour tax meeting today. Man, that sounds brutal. But I have to ask you, there's another one, I believe, Thursday, where you guys are going to hash out between House and Senate what you guys are going to do on the tax piece of reconciliation. Since I have you here and you're on Ways and Means, what are the sort of must-do things in your mind? Permanency, no tax on tips, no tax on overtime. What sort of dials are you guys looking at turning in order to make sure you can get?
We want to try to keep permanent what we did in 2017, a lot of it. But corporate tax will go to hold at 21%. Pass-through entities, there's a thing called 199A, it's a 20% reduction. It gets more parity with corporations. Full expensing is a powerful tool, whether you're buying or selling. Interest deductibility is something that we're discussing now, but we'd like to resolve. So there's a lot of things going to be done. And what we're doing is taking a look at, we've got to get to a number and what we can keep like in the basket, keep it in, and what's got to go outside of that. But I can just tell you that we're trying to get as close as we can to 2017 and bring some permanency, because it's not fair to companies where they're trying to manage their cash flow and their tax liability and stuff like that, and it keeps changing every year. Like the depreciation now, it goes down 20% a year in terms of what they can depreciate. That's just crazy. But I just feel very confident about where we're at in the process, and we'll deliver on that.
So just to recap there, permanency obviously is the goal for the previously passed Trump-era tax cuts. And then in terms of these new ones, it sounds like maybe that's not going to be permanent.
Well, I've got the bill on tax on tips, so I like it. We're just trying to price it.
How long do you think you can do it for, realistically?
Yeah, I don't know. Maybe 5 years or something. We'll see, but it's something the president wants. They asked me to pick it up and carry it, so we'll see if we get the support and get the votes and get in the caucus as well.
Well, there is a red blinking light here, which means I'm out of time, but I have to ask you. So you're going to the White House today, to the Rose Garden for Liberation Day, as Donald Trump calls it, a big day on tariffs and trade. You previously chaired the trade subcommittee. I mean, are you at all nervous about what we're going to see today and how the markets will react?
Yeah, I'm not exactly sure where the president's going to go with this, but I do think we need to build and make friends around the world. I've been to 85 countries, and we're getting ready on a trip coming up to Europe. So we need to build. When I go to these countries, my mindset is we've got a good relationship with a lot of them, but how do we make it better? And I know the president's got what he's doing, and I respect that, but I try to bring a little bit different element or vision to what we want to try to do with our neighbors. I think, especially as you look at the European countries, that's just a natural to do more in terms of trade and opportunity. That's what we're going to be working on.
Does it concern you, though, that, he's considering, the reporting says universal tariffs or tariffs for every country? Like, that's the opposite of what you're talking about here.
I'm telling you what I want to do.
Right.
Okay, I would like to do. That's the way I approach things. Mm-hmm. I tell people, we have 350 million people in the U.S., but 7 billion on the planet. We've got to find a way to work together and get along. The president's got his agenda in terms of, trying to make things in his mind fairer. But I take a little different approach from my standpoint. I'm not saying, but I'm interested like everybody else. I've got some sense of what he's going to talk about, but until he talks about it, I won't know.
I don't even think Susie Wiles knows at this point what he's going to do. So
if someone does know, it's her.
Yeah, if someone does know, it's her. Congressman, thank you so much for your time.
Thank you.
I really appreciate it. Oh. Okay. Next up, we have Politico's Dasha Burns, and she's going to be sitting down with Callie Means. Stay tuned, everyone.
Good morning, everyone. For anyone who doesn't know the man sitting next to me here, this is Callie Means. He wears several hats. Special government employee for RFK Jr. over at HHS, co-founder of TrueMed, and co-author of Good Energy, The Surprising Connection Between Metabolism and Limitless Health. If you guys have been paying attention to the MAHA movement at all, Callie is a fixture of that movement. So walk me through. We just talked about all of your different titles and achievements. What is it that you do exactly?
I mean, for me, it's just a microcosm of what has brought Bobby. It really made him today, according to Gallup, the most popular politician in America. I think there's a lot of forces behind him. But I came to this issue in 2021. It all came together. My mom abruptly had a pain in her stomach, went to the hospital, got a scan, got a text, said she had stage 4 pancreatic cancer, and died 12 days later. And this really solidified the mission for me. My sister left medical education and surgical residency after seeing inside the system, seeing the corruption of the system. I was a lobbyist early in my career, grew up in D.C. for food and pharma. And watching my mom in those 12 days, the medical system was telling her the cancer was unlucky, but it wasn't. She was on 5 medications over 40 years, the statin, the metformin, the ACE inhibitor for high blood pressure. Each step along her journey was a pill, this is just a symptom instead of explaining what's happening inside her body. So it really propelled my sister and me to think about this is happening to everybody. We're missing the warning signs. 95% of medical spending is on really managing conditions, not preventing or reversing it. And that's leading to deadly things. Life expectancy is declining in the United States for the most sustained degree in American history. So my sister and I wrote a book, went on podcasts. Those podcast hosts introduced us to the President Trump's campaign. Bobby Kennedy was able to help foster that connection after the Butler shooting and stayed close. So started a company, wrote a book in this space, and have joined as a special government employee to help with this MAHA agenda. We've got 50 items on the list. 50 items on the list that pull it above 80%. I think Bobby is really marshaling these voters behind him, and this independent media system and this grassroots. He comes into this cabinet position with more legitimacy from voters behind him than any cabinet secretary in modern American history. And I'm just dead focused on helping him just be successful with policy after policy that gives leverage and voice to the millions of voters that I think came to the Republican side to back up his agenda.
So I don't know that we have time to get through all 50 items that you mentioned, but now that the MAHA revolution has been swept into power, what is success for you? Can you define what success is in terms of policy? At a minimum, what do you want to achieve in the next 4 years?
I think this is really important. There's a lot of stakeholders in this room, and I think a lot of questions about Secretary Kennedy. I think we should all just understand what he's trying to do and what the Trump administration is trying to do, which is that in 50 years, the history books look back in this moment as the time the chronic disease crisis started to reverse. Right now, 38% of teens have prediabetes, 50% of teens are overweight or obese. We have, out of 212 countries, ranked the highest cancer rates of any country in the world, developing or developed. We spend 4 times more per capita on healthcare than Italy, live 7 years less. We're not lazier than Italians. There's something wrong with our system. So fundamentally, what we're building towards is a world where hospitals are incentivized for beds to be empty, not full, where pharmaceutical companies are incentivized to be creating therapeutics that reverse and prevent the disease, promote longevity, not just manage disease, where insurance companies are incentivized to promote health, not as they are today based on the medical loss ratio issues, really incentivized for people to get sick or costs to go up. There's a fundamental incentive problem in our healthcare system, and we're trying to start the conversation, I think, of something we can all agree, where we have a healthcare system that promotes disease reversal and prevention. How we get there, and I think what the strategy is we start doing very popular things, start working with stakeholders to build towards that goal we can all agree with by focusing on issues like transparency, like conflict of interest reduction, like benefit flexibility, and some core concepts that the administration's talked about. But we got to start getting wins.
Well, right now, it seems like the first priority has actually been to make a lot of cuts. This week, there's news of massive cuts to HHS. At this point, about a quarter of HHS's 82,000 employees have left or are expected to be terminated. So just some of the changes here, you've laid off big chunks of offices in charge of vaccine and drug research, HIV/AIDS research, AI, funding for services for the elderly and low-income people, STD prevention, rural health, with very little lead time. Right. What do you say to people in the public who are concerned now about drug safety, about whether we're prepared for the next pandemic when these cuts have happened so hard, so fast?
Yeah, I'd say to the reporters in the room and the lobbyists in the room, I mean, obviously make your case, but I'd truly ask for, as you're making it, a little bit of humility about what the voters were trying to say by putting Bobby Kennedy Jr. in this position of power. I would a little bit of humility to ask why Bobby Kennedy, along with President Trump, are the 2 most popular political figures in America by far. What the voters are trying to say, and I think they were right, is that the system is really on the wrong track. That the existing health authorities, just demonstrably, the NIH oversaw, and this is just consensus at this point, the literal creation of a pandemic. The NIH, whose goal is to promote American health, has overseen a devastation, just an abject devastation in American health over the past 20 years, with disease rates skyrocketing in America, leading the world of almost every single chronic disease, with rates of nearly every single chronic disease being at an all-time high among kids. There's been very little innovation with small pharma, with innovative therapeutics at the FDA. It costs $1 billion to get through the process. CMS is an agency that's much larger budget than the Defense Department, that's controlled by the American Medical Association, which is a pharmaceutical lobbying group and is almost predominantly sick care. So there's real problems, and when you turn on CNBC, it's just a nonstop. It's a nonstop infomercial for pharma. It's a Sky Rizzi commercial followed by Scott Gottlieb saying how Bobby's killing people, followed by a breathless coverage of the measles outbreak and no mention of the mental health crisis.
How does cutting a bunch of HHS solve that problem?
It is insane. It is insane for you to insinuate that the thing standing between us and better health is more government bureaucrats. That's demonstrably insane. That's not what I'm insinuating. That is what everyone's saying. It is absolutely insane to insinuate that it's some crime.
It's not all bureaucrats. It's a lot of scientists. It's researchers. It's people who are making sure that
those scientists fundamentally have overseen, just demonstrably, a record of utter failure. It would be insane. Is that funny? Not true. Is that not true? I'd love to hear how. So what metrics would you guys point to for how the scientific community, how the 4 times more per capita on healthcare spending that we spend in America versus other countries has produced innovation. Has there been one single chronic disease medication in modern American history that has lowered rates of the chronic disease? It is appropriate that the American Academy of Pediatrics right now, which is 90% funded by pharma, is pushing Ozempic on 6-year-olds.
So Kelly,
that is what the medical authorities are doing.
Why not then use the power that you guys have to push the existing infrastructure in that direction instead of slashing it altogether?
It's not slashing. It's taking it back to 2017 levels. That's not slashing. The amount of bureaucrats.
It's more like
exploded.
2002
There's
levels,
a fundament.
actually.
In many cases, it's actually just not that much. But it is cutting. What is it? 20,000 people. It's taking it back to. It's taking the HHS back to 68,000 employees. It is absolutely like the idea that Bobby Kennedy should not come in and make dramatic changes to the leadership and the personnel at these authorities that have overseen an abject devastation of American health, which the lobbyists in this room do not have the humility to admit that we have gone completely wrong. The lobbyists in this room laughing when we have the sickest children in the developed world. If that is your attitude, and your attitude is to tell the MAHA moms that their votes and their voice is not legitimate, that we need dramatic changes to American healthcare, if you think it is illegitimate for Bobby Kennedy to not make big changes to people like Peter Marks, who once again and again went against FDA advisory opinions, who fired the 2 top vaccine makers, the 2 top vaccine scientists at the FDA for suggesting that we shouldn't mandate COVID shots for soldiers, who continually went against expert opinion in favor of the pharmaceutical industry, who many people here were collaborating with him with. The fact that somebody like that can't be fired and he can't install tremendous people like Marty McCary and Jay Bhattacharya and Dr. Oz to start reforming these agencies and put in their people, of course he should do that. That's what people voted for.
So I think the question, though, is a lot of dynamic responses.
A lot of
in
people
the audience.
that profit from kids being sick.
But let me ask you this, Callie. Like, there's the shifting of the ideology, right, of people who are in HHS to line up more with RFK Jr.'s vision for the agency. But the way that these cuts have been made, like, I think there are a lot of people who agree with the taking away some of the bureaucracy and the red tape in government, right? But when people who are working on projects that are critical to people's health are walking into their offices and suddenly can't get in, can't finish the projects, can't do the proper transition to the new folks who are coming in. Like, was that responsible and humane too to the people that have dedicated their lives to this cause?
We are at I don't think we're understanding what the voters are trying. We are at an existential moment in American history right now. Like we have the sickest children in the developed world. We're at a genocidal.
Are going to execute on this agenda.
Dasha, you can paint breathless stories with anecdotes all the time. Fundamentally, what Bobby has done is taken over a department that has utterly failed. The CMS in and of itself has a much larger budget than the Defense Department. You know, on Medicaid, it's growing 2 times faster than the defense budget and larger, just Medicare and Medicaid alone. And as that spending happens at a higher and higher rate, kids are getting more and more sick. Like at the NIH, at the NIH, 90% of NIH funding goes to studying pharmaceutical R&D treatments to profit the pharmaceutical industry off the fact that Americans are already sick. Very little NIH funding right now goes to actually core research about why we're getting sick, about foundational scientific research. The FDA completely boxes out any innovation. It's a tool for large companies to get their large drugs approved, very little pathways for new therapeutics, AI therapeutics, therapeutics that actually can help you diagnose and understand what's going on inside your body and be more preventive.
Well, so let's go with this premise, though.
These institutions are broken. Yeah. You should. Why aren't you asking about how we can reform these institutions?
Well, I am. That's my question. So you come in, you're getting rid of the fat. You're trimming the fat, right? That's the premise for you guys. So how do you then, from there, you've come in, you've cut a bunch of people. How do you then actually move and turn the ship toward what you're talking about?
You
gonna
install Marty
Yeah,
McCary,
okay.
who is the first FDA commissioner in the past 3 decades who said he's not going to go to a pharma job right afterwards, as 11 of the 12 previous FDA commissioners have done. You install Jay Bhattacharya, who is the pinnacle of academic courage. You install Dr. Oz, who is an incredible human being, who's put together an incredible team, who's ready to reform. People that are ready to engage with industries. People that are ready to talk about improvements in chronic disease prevention, in deregulation, in transparency, in conflict reduction. You put incredible people in charge who are universally respected, and you empower them to fulfill Bobby Kennedy's mandate, get win after win after win of making this administration the time when we said enough to the skyrocketing chronic disease crisis. That's what you do. Any business in the world, if you went into it with the metrics that the HHS has overseen, with skyrocketing costs, and as costs skyrocket, worse and worse outcomes, with extremely little innovation from industry on actual chronic disease reversal and prevention, just management, you would of course fire a bunch of people. And you would of course install new leadership to put that mantle down. And this is a group that wants to work with industry, but is absolutely defiantly saying we need a new direction.
Let's talk about food, because that is an area of expertise for you. Look, becoming healthier can be expensive. Right now in America, getting food that is better for you costs more, and it is such a barrier for lower income Americans that also have the worst health outcomes. So how are you planning to bring down the cost of being healthier in America?
Yeah, one thing Bobby Kennedy is not going to do is entertain comments from food industry lobbyists using food prices as an excuse to continue poisoning children. Like, that's not going to work. And I know a lot of you guys are doing that, and I think if you really back up, that's an evil argument. That's the only argument the food industry is making. Right now, they're trying to hold a gun on food prices to literally not even dispute the premise that Americans are being poisoned. We have 10,000 chemicals in our food that are not allowed in any other country. Fundamentally, American food companies make their food with different ingredients than other countries. I mean, the food dyes has obviously been a flashpoint. American companies are making their products here with crude oil-derived food dyes and making the exact same product shipped into Canada with beet juice and carrot juice. So I think when this starts, Bobby's going to, and Secretary Kennedy's going to first talk about transparency, and that's what he's done. He's talked about GRAS standards. Fundamentally, what he's asking for is we need to understand what's in our food. The FDA currently does not have a list of what's in our food. They do not have a list. It's self-policing. So he's going to work with the NIH, work with the FDA to have a list of what is in our food and have post-market review of those chemicals. There's a lot of lobbying to actually prevent even transparency about what's in their food. There's voracious lobbying from industry about preventing, that's going to embarrass us. That's going to make us look bad. We, at the baseline, what Bobby Kennedy's saying on food is we need to know what's in it. We have to have accurate science on the chemicals in our food.
So you're talking about holding corporations accountable, making them be transparent. President Trump is a pro-business president. He wants to deregulate. He wants it easier, to make it easier for businesses to basically, do whatever they need to do for their bottom line. How does that jive, and how much has he empowered Secretary Kennedy to try to regulate some of these companies?
President Trump is the defining figure of our time politically because he stands for anti-corruption. The MAGA movement stands for combating the swamp against whose interests are against the American people. So what President Trump and Secretary Kennedy do not stand for is things like the food stamp program SNAP, the #1 item going to soda and subsidizing soda. It doesn't stand for the food industry being able to self-police and have less healthy chemicals in our food. It doesn't have, stand for, frankly, a system that has really incentivized and recommended ultra-processed food. The USDA guidelines under Biden recommend sugar to 2-year-olds. It actually said recently, just a year ago, that a diet 93% in ultra-processed food for a child can be healthy. So what President Trump and Secretary Kennedy have talked about, it's not pro-business, anti-business, it's anti-corruption. We should have scientific guidelines that are not corrupted by industry that tell Americans the truth. We should have transparency for American consumers and lawmakers of what is in our food. We should start with transparency and the truth. That's what President Trump did with his executive order on the MAHA Commission, which is not going to talk about policy. It's just going to lay out the truth of why kids are the sickest in the world, something that lobbyists here are hissing at, something that lobbyists here, for some reason, have no self-awareness or humility for the state of American children's health. President Trump is standing with the voters, and he's like, at the one baseline, the first step of MAHA is acknowledging the truth so we can all make decisions and get to a place we probably all agree with, which is a system that reverses and prevents disease, a system that gives patients more autonomy and choice over their healthcare decisions.
So has President Trump given Secretary Kennedy the leeway to say, go to town on these corporate interests if it means making Americans healthier?
I don't think it's go to town on corporate interests. I think it's let's get Americans the truth. I mean, it's just not clinically accurate, for a 12-year-old who is struggling with their weight to be told that obesity is a genetic condition, they should go on Ozempic for life. It's not clinically accurate to tell a 12-year-old who's a little bit sad that the standard of care should be going on SSRI for their entire life. SSRI prescriptions have doubled among high schoolers.
Right.
That's not that is what clinically the American Medical Association is saying and is filtering through our Medicare and Medicaid codes. What MAHA is trying to do is there's obviously going to be a lot of work and a lot of lobbying on the Medicare, Medicaid reimbursement rates, but there's something fundamentally, and I think everyone can agree, fundamentally broken with the incentives of our healthcare systems. Clearly that's the case when you look at the graphs about what we spend versus our outcomes.
But a big piece of that is corporate interests, right?
I don't know what you mean by corporate.
I mean companies that sell junk food wanting to...
I think President Trump and Secretary Kennedy say if your corporate interests are profiting from children being sick, you should be worried. Your corporate interests need to be preventing and reversing disease for the American people.
But
I don't see it in this framework. Nobody talks about in this framework. President Trump and Bobby Kennedy never talk about it.
You said these companies are poisoning kids.
No, I'm saying these companies are profiting from the American children being sick, which is a demonstrable statement of economic fact.
Right. So that means that Kennedy will be potentially going after some of these, making them change what they are doing.
Well, there's a clear voter mandate to have a healthcare system that reverses and prevents disease. I want to be really clear.
Yeah.
I don't see Secretary Kennedy being vengeful or really anti-corporation in any degree. I think there's actually a feeling that this is a group effort, what's happened in the past 40 years. I think most people in this room would agree. There is not a finger pointing happening right now. There is not backwards looking retribution. There is a moment we all have in America right now to acknowledge that we have a problem and acknowledge that problem is multifaceted. That problem is because of $1 trillion of agriculture incentives over the past decade that have led to an ultra-processed food system, that have led to American children 70% of their diet being ultra-processed food when it's 10% in Japan. It's not right. That's because of incentives. They're not pointing a finger at industry. This is a group effort that's happened. It is a extremely complex group effort.
How do you get industry on board, though?
Everyone can agree with the goal of having healthier kids. I think everyone can agree with the 10-year goal of having a system that reverses and prevents disease. Everyone can agree in 10 years, it's going to be very complicated to get there. We have a thriving healthcare sector, which is making a lot of money by promoting disease reversal and prevention and longevity for the American people. Everyone can agree with that. Now, there's thousands of steps to get there. What I would say to industry is what can we do to start getting wins right now? There's a lot of great communication that's happening with industry right now. There's hospitals that want to promote more, value-based systems, want to promote a system where they're paid when patients are healthy. There's, many interests that want to see more healthcare flexibility, take advantage of and support Bobby Kennedy when he said, let's get Medicare and Medicaid not to a top-down system where you jab certain pills down kids' throats who are sick, but actually have a system where there's more HSA-type accounts for Medicare and Medicaid, where a mom with their kid who's depressed and obese, could take the pills, but also get that kid on a functional medicine program, get more blood tests.
So the idea is to expand access to different kinds of treatments via Medicare and Medicaid?
Two big principles Secretary Kennedy's talked about. It's let's get patients the right information, let's get gold star science, and then let's trust the American people to make the best decision with their doctor. We actually very much have a top-down system right now with Medicare, Medicaid, private insurance, which is really beholden to medical codes that are sick care codes. It is get American patients the truth. Let's have transparency. I think there's a lot of interest in this room that would like more transparency. There's pharmaceutical companies that feel like they have great data and actually want that data to be out there more. So it's transparency. It's asking fearless questions. It's being led by Jay Bhattacharya, who represents that more than anyone. We're not going to be afraid to give American patients the truth. The truth, by the way, which is really prevented often by lobbyists of the truth getting out because it could be embarrassing to industry. But it's not about backwards looking. I want to make that really clear. This is a group effort where we are. It is about looking forward, not reclamations to the past, and having the truth about what our standard of care in America could be, and then letting patients make the right decision. This is not top-down, kind of mindset of dictating the American patient, eats broccoli and exercises all the time. It's giving Americans choice and steering that $5 trillion nearly that we spend on healthcare to how do we incentivize prevention and reversal, not just management.
The access is a big part of that. I mean, let's talk about SNAP for a second. You all are suggesting that SNAP benefits not cover soda, right?
Yes.
What about the flip side of that? How do you make healthier foods more accessible? Because right now, for a lot of SNAP, people who are on SNAP, those stores that they're going to, it is mostly soda and junk food.
Well, I disagree fully with the premise that it's going to hurt kids to take away soda from SNAP. Just fundamentally.
That's not the premise
okay.
That's not what I'm asking. I'm asking, are you also thinking about the flip side of how to make health, not just taking away, but also making healthier food more accessible?
Bobby Kennedy stood with the governor of West Virginia, who submitted innovative waivers on work requirements on taking soda off SNAP, and he explicitly encouraged governors to come to him for waivers. There are now governors speaking to him about actually innovative waivers to increase funding if you steer it to healthy food. There's a lot of state latitude with SNAP. It's a great example of a state.
Can you use that model nationally? Is that something that you would
Bobby Kennedy is encouraging every single governor, and he's talking to red and blue governors, to call him, to work with Secretary Brooke Rollins, who's tied at the hip with him on this, and they're encouraging state innovation, which can include both taking objectionable food, clearly objectionable food, off of SNAP. A lot of lobbyists here it's just unbelievable. They're arguing that it's important for childhood nutrition to have government subsidized soda. That ship has sailed. We're encouraging every single governor to take soda off of SNAP and bring innovative ideas of how to incentivize or potentially even bring more money to healthy food. Absolutely, SNAP should be a program that is supplemental nutrition. There's a ton of latitude that state governors have, and we are encouraging every single governor, this is an unimpeachable issue, work with the USDA, work with Secretary Kennedy on innovative arrangements, and the federal government is open for business to discuss these waivers, which can include both the incentive side and taking off injections.
Yeah, so on the federal government side, I mean, you talked about all of these 50 items that you guys want to get through over the next 4 years. Going back to the accessibility of healthy food piece, I mean, can you talk about any specific plans you guys have to make it easier for especially low-income Americans to build healthier habits and have access to healthy foods? I mean, right now, so many people live in food deserts. People don't have the ability to afford better food.
Well, the food deserts, I'd argue, are largely an invention of SNAP. I mean, this is a large program. This is a $120 billion program. It's the fourth largest entitlement program. This is a huge distorter of, worldwide agriculture incentives. The fact that 60 to 70% of SNAP goes to ultra-processed food when no other country in the universe.
But again, my fundamental question: how do you get people there? How do you get
if
people
you take soda and healthy food, soda and unhealthy food off of SNAP, foundationally, economically, that opens up tens of billions of dollars of more money to healthier food, which then correct the food desert issue, because the food deserts are there because the majority of their money go to SNAP, and SNAP goes to ultra-processed food. Secondly, when we talk about the two prisms of MAHA, about let's get American patients the truth and then have flexibility, foundationally, and Bobby said this defiantly last week, food is medicine. We spend $4.9 trillion now on healthcare. 90+% of healthcare costs go to foodborne illnesses, essentially, go to chronic disease, which are interconnected. The medical system said diabetes, obesity, dementia, other conditions are siloed conditions, which we need different pills for, different NIH institutes. These are all interconnected conditions. So when we talk about healthcare flexibility, when we talk about giving Americans, more control of their healthcare, that does get to a system where we drive healthcare dollars to the clinically best intervention for that disease. It is demonstrable clinically that often these diseases are food related. So when you talk about the lobbyists here trying to jab Ozempic into the arm of 30% of 6-year-olds, right? I would argue clinically, maybe sometimes Ozempic's warranted. Maybe it's not an anti-drug situation, but Often that 6-year-old needs better food. Often that 6-year-old needs to drive healthcare dollars to a diet coach, to some functional medicine blood tests to understand their nutrient deficiencies. And yes, have some medical incentives to food as medicine. That's what we're talking about with healthcare flexibility. The long-term goal of this administration is to have science, and Jay Bhattacharya has said this very clearly. He wants to understand the root cause of disease, which often goes to food, and then have the medical dollars go to the most efficacious way to prevent and reverse that disease. And if that turns out from the research increasingly to be food interventions or root cause interventions, then it would stand to reason, like in Europe, where if a woman has PCOS, she gets a insurance subsidized keto diet because PCOS is insulin resistance, which doctors don't learn here, and can be reversed in 12 weeks, often with a keto diet instead of jabbing that woman with hormone pills.
That means funding, though. So do you want to keep the money
$4.9 trillion
for
of
Medicare and Medicaid steady, or do you want to see cuts to Medicare and Medicaid?
What does this have to do with cutting Medicare and Medicaid? I'm saying nobody disagrees that Medicare and Medicaid should be going to the most efficacious treatments to reverse and prevent the diseases Americans have. Nobody would agree with that. The problem isn't the Medicare and Medicaid policy. I'm not talking about that. I'm talking about what's the logic that oversees Medicare and Medicaid. What's the clinical logic? Right now, the clinical logic is that if a kid has high cholesterol, statin. If a kid is sad, SSRI. If a kid is obese, Ozempic. That's the treadmill that we're on. 35% of teens are on a chronic disease medication, and the chronic disease rates are skyrocketing.
What is the policy solution to that, though?
Have better NIH research that identifies what's causing and what can prevent or reverse disease.
So the cuts to NIH research, will they be restored then? Because you need money to do that kind of thing.
The Medicare and Medicaid is driven by scientific inquiry that sets the standard of care. Right now, the standard of care is wrong. The standard of care is led by the AMA. Medicare and Medicaid is only as good as the logic that underlies it. How to solve that, how to create more efficacious treatments and more food as medicine. You have NIH research that shows what's causing disease. We have very little research on how food and lifestyle interventions relate to disease. You have more FDA approval pathways for root cause therapeutics, for preventative scans and treatments. And then you have better FDA deregulation at the FDA, more NIH research about how root cause lifestyle interventions impact disease. That folds into standards of care that underlie the payouts for insurance.
But Callie, I'm not questioning that piece. I'm questioning how you do all of that research and work when you're slashing it and cutting.
We're not. Has NIH funding been slashed?
Yes.
No, has research has not been cut.
The funding has been cut.
Research funding has not been cut. The NIH now has the indirect funding does not. Indirect funding. It's amazing. It's amazing how many people here care about the health of American children. I'm actually inspired. Thank you for the care. Thank you for the care. The administration has put out guidance that they want to direct and cut indirect funding. That fundamentally means more money is going to researchers. The guidance that Bobby Kennedy and the Trump administration put out means more money is going to frontline researchers to do research. There is a very clear signal, demonstrably, with what is happening, which is that government bureaucrats are being disempowered and more money is going to actual researchers. They are hissing about changes to a system that has caused absolute devastation to American health, about policies that give more money. Today, more money will be flowing to actual researchers, not university bureaucrats, not government bureaucrats, actual researchers. Not a dollar of services has been cut. There has been an attack on bureaucracy, both with the indirect funding because of the NIH, not money. Harvard was getting 70 cents on the dollar, not for research with a grant, but for bureaucracy. Cutting indirect costs gets more money to researchers. People can believe this or not. There is a absolute fixation in this administration on empowering researchers, on getting money to scientists and not telling them what the answer should be, not telling them what to study, asking them to do bold research on why we're getting sick.
I actually do understand that. It's the friends that I have and the people that I know that are in research. Unfortunately, there are bureaucracies at these institutions as well. And when you cut funding, it does end up trickling.
The rank
down
and
to
file
the people
researchers
doing
are
the
very
work.
excited about what's happening.
So let me ask you.
The pharma lobbies are not.
I will tell you, I know researchers who are very, very concerned, but let's see how this plays out. I do want to ask, because I have to let you go, but there's been a lot of concern about the measles outbreak. Secretary Kennedy received some criticism because he was not really out front on this issue, and people are wondering why.
Well, the media can write, I think, process stories about Bobby Kennedy taking over the largest department in government and different operational issues. But I think Bobby Kennedy is very concerned about the measles outbreak, and his administration is committed to the best possible responses from the CDC. And he's getting his team together. There's a absolute commitment to best-in-class infectious disease responses. I would also say that it's interesting to me that the level of reporting on one measles death and the utter lack of interest in this room and in the media, quite frankly, about the 38% of teens who have prediabetes and the hundreds of millions of Americans that are being savaged by
I think we've talked about that actually quite a bit in this conversation,
I think
which
it's been
I do
very
appreciate.
little talked about generally, and I think that there is a huge commitment to get the measles outbreak under control and have best-in-class response to that. But
why
it
did
is
it take
very
so long
interesting
for Americans to hear from the Secretary of Health and Human Services in the midst of a real crisis?
I mean, in his first week, I think he put a statement out and responded quickly. I can't talk to the process of the couple days. And
why hasn't HHS been out front saying, get vaccinated, make sure we're preventing this disease?
I think they've made very clear statements on that.
All right, Callie, my time is almost up. I just want to ask again, big picture, stepping back, the vision. How is American healthcare different 4 years from now?
The NIH has been shifted to asking how can we understand what's causing American sickness. 80% of the NIH budget is going to true innovations to reverse and prevent disease, not figuring out how to manage disease. The FDA is much more deregulated, is encouraging innovation from therapeutic makers, from preventative device makers. We've overseen the true inflection point for AI and technology and how it can help prevent and reverse disease at the FDA. We've ridded the FDA of conflicts of interest, which are an absolute scandal. And that work has led the CMS department to work with Medicare, Medicaid, and private insurance to evolve the standard of care towards the science, which is that we are being hobbled by an interconnected set of lifestyle conditions that our medical system currently does not incentivize reversal and prevention techniques for. And the CDC has best-in-class infectious disease procedures while also focusing more on their remit to prevent and reverse chronic disease, which is an area they have completely ignored thus far. So we have foundationally a system where everyone in this room who thinks Bobby Kennedy is crazy, in 4 years is thinking a little bit more about disease reversal and prevention. That Bobby's gone and that the paradigm, because of the will of the voters, has been shifted just slightly to where in 4 years, 8 years, you guys can still talk about how Bobby was a whack job, but we're talking about more prevention and reversal, and we're not fundamentally having a healthcare system that, just as a statement of fact, is predicated on more people and more Americans being sick, which is what we have now.
I will say I don't remember another time in history when there has been this much talk in politics about chronic disease, about childhood disease.
No thanks to a lot of lobbyists in this room, but we're very glad the American voters have pushed that forward.
I hope we can keep the conversation going. Thank you guys. Appreciate it. Thanks, Callie.
Thank you.
Hi, guys. Let's get going.
Boy, that wasn't a break.
Good morning. I'm David Lim. I'm a healthcare reporter here at Politico, and joining me today are two members of the Health Subcommittee on the House Energy and Commerce Committee, Democrat Representative Jake Auchincloss and Republican Diana Harshberger of Tennessee, to talk about pharmacy benefit managers, otherwise known as PBMs. Thanks so much for joining us today. I want to kick things off by asking about the impact of the news of this week. The 10,000 people who were fired at HHS. And I was curious, with so many senior staff departing at the department, how does that impact the possibility of bipartisan agreement towards a pharmacy benefit package this Congress?
Yeah?
Sure.
I mean, I think what we just heard explains and crystallizes the arrogance of these bros that have descended on Washington, D.C. I mean, these professional podcasters stand in front of a bunch of career scientists and say, what has science ever done? Oh, I don't know. Science eradicated measles until 2 months ago. Science means that a kid who grows up with cystic fibrosis now has a real chance at life. Science means that women who give birth now don't face a 1 in 5 chance of dying. They can now build families through IVF. Science is core to who we are as Americans, and their excuse for destroying our scientific enterprise with their conspiracy and quackery is because they're the first ones who ever thought that chronic disease was a problem. Michelle Obama 15 years ago was talking about this. Blue cities like New York City and Philadelphia were doing this, and Republicans were saying, don't touch our French fries. But this guy, all of a sudden, he's the first one to ever realize that chronic disease is a problem. We will not take a lecture from people who are based in conspiracy and quackery and who are claiming the moral high ground on corruption when Brad Smith, who is running health and human services for DOJ, is hiring and firing his own regulators. Main Street Health reports to CMS, and he's deciding who gets to be there or not. This corruption and chaos will not stand. The American people will not stand for it. And Democrats are going to draw the contrast.
Do you have a response, Representative?
Well, Jake's on fire today. So, well, let me tell you what we talked about in the committee hearing yesterday. And Jake was there, so was I. It was a health subcommittee hearing. And our chairman absolutely said that we're going to find out what the layoffs were all about, 10,000. We didn't know it. And we're going to find out what the premise was for those layoffs. Now, listen, I've been a pharmacist 38 years. I've done clinical, sterile, non-sterile. I've done functional medicine, anti-aging. I've done everything you can do in pharmacy. And when it comes to evidence-based medicine, that's what we set our research on. And we've been involved with clinical trials and the things that really matter when it brings medication to the forefront. There's a lot of things that we need to do. And I've said this since I've been here for the last 4 years. If I could restructure every 3- and 4-letter agency, I'd do it in a heartbeat. Because there's things in every agency that need to be looked at, that need to be adjusted, that we need to recalibrate to be the most efficient agency that we can be. And what falls under our premise and under HHS is the FDA, the CDC, the NIH, and CMS. Every one of those agencies have faults. And, you know, when we found out that there were 700 different working systems in NIH, for example, and none of them talk to each other, that's a problem. Because how would you ever see and be on the cutting edge of science and evidence-based science if you can't have programs that talk to each other to know what the new modalities are going forward? In the same way with having 27 CIOs or chief information officers in NIH, you can't do it. And as far as, I heard a question that they asked Kelly Means about cutting funding for NIH as far as the administrative portion. Look, the NIH was set up after World War II, and they had to have that huge administration fee to set these teaching facilities and research facilities up. When you scale back to what it should be, the 16% or whatever, they still have the money for the research. Don't go into the fallacy that they won't have money to research, do cancer research and things of that nature. We absolutely keep up with that kind of thing. So we have asked for an inquiry with HHS as far as those 10,000 go, and they were laid off, is what I understand, the potential layoffs, and then they were laid off. But we need to find out. It's just like what happened with USAID. What happened? They got rid of a lot of programs, but the head of that department, who was Secretary Rubio, went through line by line. How many of you have a budget? David?
I have a budget.
You have a budget. You go through line by line, and you know exactly where that money goes. That's all we're trying to say is this a good use for taxpayers' money? Because as representatives, Jake and I both are responsible for those taxpayer dollars. So there's not, it's like an audit or oversight.
Right, but
that's what we're doing.
But we're responsible.
Yes, we are.
Congress, Article 1. Nobody gave a mandate to DOJ to take a chainsaw indiscriminately to programs and budgets that Congress authorized and Congress appropriated. Speaker Mike Johnson is not a courtier. He's a congressman. He has a responsibility as the leader of a separate and co-equal branch of government to do his job. I'm not asking Republicans to agree with me on policy. I'm asking Republicans to stand up for Congress as an institution.
Well, remember, Elon Musk cannot fire one person. He cannot take $1. Well, that is our job. He's just bringing those to the surface so we, as a Congress, can make those changes.
It was just reported yesterday that Brad Smith and his assistant, Rachel, have a spreadsheet that no one's allowed to see, including RFK. RFK, by the way, is not running HHS, if any of you think he is. No way. They have a spreadsheet that no one's allowed to see, and they are the ones who determine who gets cut and who gets fired and who gets hired. And lo and behold, Brad Smith's regulators at CMS are the ones who are spared the cuts, but career scientists at the FDA who would have the gall to tell RFK that, actually vaccines work, are the ones who get purged. That is not Congress stepping up and doing its job. We need hearings in Energy and Commerce, bringing RFK, bringing David Geyer, bringing all of these quacks and conspiracists in front of us to lay out the evidence that they are claiming for their mandate to bring back infectious disease in the United States.
Well, we'll have those hearings, I'm sure.
I hope that they will be scheduled because I have seen zero evidence thus far. Yesterday we were doing a hearing on over-the-counter drugs. Great. It's an interesting program. It's not the near-term fire right now that we got to put out.
So going back to the question, we saw PBMs.
What was the question?
We saw a PBM deal at the end of last Congress almost come together. Then Trump spiked that legislation package. I just heard a lot of disagreement between you two over kind of the response to RFK. But do you think that there still is a possibility for bipartisan PBM legislation this Congress?
Not if Elon Musk tweets about it again.
Well, listen, yeah, I do. I think so. And the president's even said that he wants to do PBM reform. Look, you cannot fix a problem if you don't understand it. And being a pharmacist all these years, I've seen this firsthand. I remember when the PBMs first came into existence, and we would slide a credit card machine that had PCS on it in triplicate, and I would mail that in to get reimbursed. And they were there for a fee for service. It has changed drastically to where the vertical integration, and who owns most physician practices in this country? United Healthcare. And then it filters from there. How can you have an insurance company who owns the physician practice, the pharmacy, the specialty pharmacy, the PBM, and then the clearinghouse? It is not good health care. And we have less choices. And Jake, you know this, there's 3 PBMs that do 80% of the business in this country. Do you think that's a good thing? Listen, competition makes everything better, and choices make everything better. And right now we don't have that. If you looked at the current FTC reports and what they've uncovered, it's a travesty. It's what I've been saying for 30 plus years. Why did I come to Congress? Because I talked to my congressmen and my senators for 25 years on the Hill. And finally I raised my hand and said, I'll do it myself. And so I came to Congress. And so this is where we agree that we will have PBM reform. Everyone's talking about it. And I think the PBMs are getting a little bit nervous.
Let's talk about your bills. The Pharmacists Fight Back Act and the Patient Before Monopolies Act. My understanding is that the first sought to create a pharmacy reimbursement model that pegged the national average drug acquisition cost and that pegged reimbursement to that. And then it also aims to prevent PBMs from steering patients to pharmacies that they're affiliated with. The second kind of goes off of what you were just talking about, which from my understanding, would prohibit a parent company of a PBM or an insurer from owning a pharmacy business. Is that a fair characterization of the bills, and are there other aspects that you want to highlight?
I think the overall characterization of the bills is that Representative Harshbarger and I are skating to where the puck is headed. So PBM reform that got yanked at the last minute last Congress, that's kind of, think of that as like the basics of PBM reform, the absolute imperatives, Part D delinking and transparency and spread pricing in Medicaid, the basics. Now, I don't know why Mike Johnson hasn't brought it to the floor. I don't know what kind of clause the health insurance lobby has in him, but he's not doing it. But once we get that done, our bills are what's next, because where we are heading towards is what the big three PBM CEOs are bragging about on their earnings calls, which is specialty steering, which is the fees from group purchasing organizations, and which is their ability to manipulate their markups vis-a-vis independent pharmacies. And so we're getting ahead of those issues with our bill that has NADAC cost-plus pricing and specialty steering bans and GPO transparency. We're the next up.
So I want to ask about that. So it doesn't sound like you think that there's a path for these two bills to be included in an initial PBM package. Is that correct?
I don't know what the path is for the initial PBM package. Mike Johnson will not bring it to the House floor. I mean, it started with a tweet from Elon Musk, but now it's been 3 months, and I wonder, is it PCMA? Is it the health insurance lobbyists? What are they saying to him in his office? Because he won't bring it to the floor. It would pass immediately, day one.
Well, we need to, and we've talked about that, and I've talked to the Speaker about that. And looking at reconciliation, what we're getting ready to do, there has to be a monetary value attached to that. And so we will get that. I just don't know when. And it's one of those things where this is where Jake and I agree, believe it or not. And the next bill, when we talk about the patients before monopolies, when did you ever think I would agree with Senator Warren on anything? But I do, because it's one of those, if you have a PBM or an insurance company that owns a pharmacy, I don't think that's cool. And I think there's a conflict of interest there, that you steer those patients. And, you know, they might be able to come to my pharmacy and get it the first time, maybe twice, but then they have to do mail order. And these mail order pharmacies, people are getting what they think is the right medicine, and then they'll come to me and ask me what it is. So bottom line is we have to do something. And the bill states that if you're a PBM, if you're an insurance company and you own a pharmacy, well, you're going to have to divest. And we'll give you a period of 3 years to do that. And so that's going to be good for the practice. That vertical integration is not a good thing when it comes to health care. You have less choices and it's more expensive because they can charge what they want. And they're trying to drive the independent pharmacies out of business because it's a take it or leave it contract. You will reimburse whatever they decide to give you, but if you look at the FTC report, you will see that if it's their pharmacy, they get massive reimbursement. If you're an independent, I might lose $100 a prescription, and I can't afford to stay in business if I continue to do that. So this is where we agree.
Let's talk about the other PBM news from yesterday. The FTC, which you just talked about, paused its enforcement action that alleged that PBMs used illegal rebate programs to increase the price of insulin. That happened because the FTC General Counsel said there's a lack of sitting commissioners that are able to participate. 2 of the commissioners are recused, and 2 were fired by the president last month and are suing to be reinstated. What is your view of the FTC's in-house antitrust action against the PBMs, and do you think that this is an appropriate development? I'll start with you.
It's an example of a mischaracterization by DOJ of efficiency as cutting things versus efficiency as high return on investment. When you fire all of FTC and then you can't prosecute corporate greed and malfeasance, okay, maybe you saved some salaries at FTC, but did you get a return on investment for the American public? When you closed the Office of Pharmaceutical Quality in St. Louis that tests for toxins in our pharmaceutical supply chain, did you save money on the lease? Yeah, I guess. But then if you have toxins in our pharmaceutical supply chain and you have a massive drug recall, did you get a return on investment for the American public? The conception of what efficiency looks like is so deeply broken and fraudulent that's coming out of DOJ that everything they're doing lacks credibility. Even some of the things that they stumbled to that are maybe a good idea, because they're clearly approaching it from a position of a chainsaw rather than as a, how do we put $1 down and get $10 back for the American public?
But in terms of the FTC's in-house antitrust action, do you think that
I support it, but as you said, they can't do it because they fired the FTC commissioners.
Representative, do you have a response?
Well, I guess when you're elected president, you can hire and fire who you want. I mean, you work at the pleasure of the president. If the bottom line is this.
It's an independent agency.
Well, that's what they say.
Authorized by Congress.
It is authorized by Congress. We've authorized a lot of things that I'd get rid of, honestly, but...
And Republicans can get rid of it from Congress. That's your right. You got the gavel.
Exactly.
You can authorize things, but the president cannot decide from Article 2 to dismantle things that Article 1 authorized.
Well,
that's the separation of powers.
Listen, Jake, I'm all about looking at what they've done and then going back with a fine-tooth comb and trying to figure out, do we need this? Do we not need this? Is it your prerogative to do this? Listen, I'm right there in the same boat. But the bottom line, the antitrust with the FTC, there's going to have to be something done. We are giving up our legislative authority to these agencies, and we shouldn't have done that. We instituted these agencies to protect the American taxpayer, but yet again, we don't legislate on the things that we need to legislate on. If we focused, we could change the way this place works.
So two
and
questions.
That's my goal.
Just to follow up on that.
Yeah.
Do you think that it's appropriate that the president removed commissioners on the FTC explicitly?
I don't know what his reasoning was, but I guess it's up to him as to what he does. And I would like to know why.
We should call a hearing. That's the thing that we can do as members of Congress. We can call a hearing and ask the executive branch, why did you do this? And if you don't give us answers,
I got above, Jake. We had the hearing with the FTC commissioner that was fired, and all she wanted to talk about was she got fired, she got fired, she got fired. She didn't even ask. We asked legitimate questions in that health hearing. But everybody on the other side, it was all about the unjust firing and are you going to sue? That's not, we shouldn't be bipartisan when it comes to that, or partisan when it comes to that. If we have a hearing, we need to be talking about what the hearing is about. And if we want to call a specific hearing, we need to get them in there, and we need to do that.
So will you call for a hearing to investigate the FTC
Listen,
firings?
I can talk to the chairman, and he's already asked them. He's put a request in to find out about the firing.
I don't want, the chairman of Energy and Commerce should not make requests of the presidency. He demands things. That's what happens when you're in Congress. You get to tell the executive branch that they are coming to testify in front of the American public.
When our chairman yesterday said, look, they were angry about that, and then that's when they called and said, look, we need to bring them in. Yeah.
Do you support the FTC antitrust action against the PBMs with regard to the insulin pricing?
Well, we'll see. Yeah, I mean, look, there's manipulation with all these drugs, not just insulin prices. I mean, if you look at their pharmacies, look at the report, the second interim report, and it talked about what they reimburse a retail pharmacy, one of their pharmacies, or maybe a hospital pharmacy or whatever. Phenomenally high, from $27 to $9,000 to $26,000.
Let's really quickly jump to another question before we wrap up. I want to ask about Optum Rx, the recent announcement that they would shift to a cost-based reimbursement model over the coming years. They say they're going to try to cut down on prior authorization rates. They also said earlier this year that they want to pass through 100% of rebates negotiated with drug makers to their clients. Do you see these announcements as concessions given the environment, or are they policy changes that you see as legitimate?
No. This is classic rearguard obfuscation, because what they're really going to do is they're going to funnel their profits towards two other sources: the group purchasing organizations domiciled in Switzerland and Ireland, and specialty steering. The whole rebate game is already over. They're already passing through their rebates. That profit pool has already shrunk. The next profit pool, and where Rep. Harshbarger and I are skating to with our bills, is the specialty steering, is the GPOs. So this is a press release. This is not policy.
Yeah, and I agree. I have a Stark Law clarification bill in the Senate, and it's been held up because some specialty pharmacies are balking at it. And it's where oncology drugs, during COVID, you could mail those to the patient. These are oral chemotherapy drugs. Well, the CMS came back and said, oh, wait a minute, we're going to take that back. The patient has to come. You can't get a caregiver. You can't get a family member. The patient has to go pick those up from the oncologist. Do you know what the outcomes are going to be on those patients who have no resource to get back and forth? It's going to be detrimental. And my bill would clarify that. It passed out of committee and out of the House, and it's sitting in the Senate because Specialty pharmacies are holding it up. And that's not right. That is not right. I am not here. I mean, I'm a mother, a wife, a mother, a grandmother, and a business owner, and I didn't come here to waste my time. I came here to change the way healthcare is done, administered, and we're on the path to getting that done. We just got to put our pedal to the metal and push it forward.
As a closing question, let's get your predictions on when Congress ultimately will pass any sort of PBM legislation. Do you have a timeline that you're expecting?
He's in the majority.
Let me look at my crystal ball. Well, soon.
Soon? Reconciliation?
Yeah, soon with an exclamation mark. And it's going to be us that drives the bus, and we're going to have to push that. And, you know, you got to be a little forceful. You got to say, bless your heart at the end of everything. And you know what? They don't know if you mean it for good or bad, and that's what I'm going to go in. And they're going to have to figure out what I mean, and then we're going to have to push it, Jake. Now, I haven't said that to my pal here. I've never said that, and I won't, unless it's a good thing.
This year? Is that what I'm hearing?
Well, let's hope to God that it's this year. We've got a 6-month CR. We have to do reconciliation.
What I can tell you right now is that if Hakeem Jeffries were Speaker, we would have passed this bill already.
I think that's a good place to wrap up. Thank you so much for your time this morning. Next up, we'll have Representative Diana DeGette, who will sit down with my colleague Robert King. Thank you.
Thank you. Don't tell me that.
All right. All right. Great. Well, thank you. Thanks, everyone, for being here. My name is Robert King. I am the CMS reporter for Politico. And I'm so happy to be here with Democratic Congresswoman Diana DeGette of Colorado. And I wanted to first kind of dive right into the news of the day, or I guess yesterday, when there was a major reduction in force notice that was sent out across HHS. And I wanted to get your initial thoughts on this kind of wave of firings, and what is the reaction that you have been getting from your constituents and from other people in the healthcare industry?
Well, thanks for having
Sure.
me, and I'm really happy to be here, especially on the heels of that spirited debate in the last panel. I'm happy to be here to kind of back clean up, and I will say that this announcement this week by RFK Jr., Donald Trump, and Elon Musk is the most devastating thing that I have seen to happen to biomedical research in the nearly 30 years I've been in Congress. And I don't say that lightly, but our biomedical research, device and drug approval, and public health that we do at the CDC is the gold standard for all of the whole world. And what the administration has done through these cuts, it's not just layoffs. They've also been slow walking and canceling research grants for critical research across the country, not just at Bethesda, but also at places like Anschutz Medical Center in Colorado, right outside my congressional district. They've been canceling research grants. They've been laying off researchers and professors, and they have been doing it in a way that is completely without any kind of rhyme or reason. It seems to me their main goal is just to meet their goal of firing 20,000 people without regard of who they are or what they do, and also consolidating institutes. So it's not just devastating to the future of research or to the gold standard of the United States in these areas, it's also illegal. And this is what my colleague Jake Auchincloss was just trying to say in the previous panel. Congress, under Article 1 of the Constitution, has the ability to authorize these agencies. And when we heard about this last Thursday, I'm a lawyer by training, and I thought to myself, this is illegal. And the reason, and so I went home because I'm a nerd, and it was like 11 o'clock at night, I got online, and sure enough, all these agencies, plus all the institutes at the NIH, are all authorized by Congress. And so I think we need to make our agencies work as best they can and as efficiently as they can, continuing to do this research. And that's why in 2006, some of you might recall, Congress worked together, Democrats, Republicans, House, Senate, with the White House and the agencies to restructure the NIH. Remember that? Mm-hmm. And then in 2016, Fred Upton and I, Republican from Michigan, we worked with Dr. Francis Collins, and we worked with the Obama administration, and again, House and Senate, Democrats and Republicans, to pass 21st century cures. So we should and can be doing it, but not in a meat-axe manner. I will tell you that the response I've been getting is horror. I've been getting calls from former senior officials at these agencies, not just Democrats, but Republicans. I've been getting calls and pleas from researchers. The patient advocacy groups, they're worried that we're going to stop doing pediatric cancer research. And privately, many of my Republican colleagues have been expressing concern and fear, although they're too afraid of Donald Trump to say anything publicly. Okay. So that's what's going on right now.
So that's a good segue. Not a lot going on, I suppose, but that's a good segue actually into you serve on a committee that has a very bipartisan history, energy and commerce. You just referenced 21st Century Cures, which was a major bipartisan achievement. You know, how will these cuts impact your relationship with Republicans on the panel? I mean, does it mean that there's going to be less likelihood of bipartisan support on other issues, things like the Support Act as well?
Well, so you're right. Energy and commerce, particularly when it comes to healthcare policy, particularly when it comes to our public health and biomedical research, we've always worked quite well on a bipartisan way. And this is why I'm saddened by the fact that the Republicans in Congress seem to have abrogated their authority under Article 1 of the Constitution to the Trump administration. But you know something? Disease doesn't just impact Democrats or Republicans or even unaffiliated voters. It impacts every family in America. And so I know those of us on the Democratic side of the aisle are willing to continue and eager to continue working on these very important issues. But we don't think that Congress should be used just as an organ to rubber stamp anything the Trump administration wants to do. We think we should have oversight. We think, all the members, the Democratic, I'm now the ranking Democrat on the Health Subcommittee in Energy and Commerce, and all of the Democrats on that subcommittee sent Secretary Kennedy a letter early in the session, right after he was confirmed, asking him to come and testify before Congress. They usually do that. But there's been no indication that that's going to be scheduled. I'd like to have him come over and explain how he thinks his healthy initiative and taking cod liver oil or vitamin A is going to help pediatric cancer or rare diseases.
We've heard that some Democrats are potentially reluctant to support things like COSA and support. Is that an area of leverage potentially that the lack of support could be used as a way to kind of help address or mitigate some of these cuts?
Well, I think that, of course, we were supposed to have a markup of some of these bills tomorrow, but since Speaker Johnson apparently doesn't want to give maternity leave to young congresswomen, he vacated the votes for the rest of the week, and the whole markup got canceled. So I suppose we'll have that markup, and I think people will look at those bills one at a time. But as Congressman Auchincloss just said, that sort of again ignores the issue that we had this great big agreed upon package in the continuing resolution last fall, 51 separate bills, many of them healthcare bills, things like the special diabetes research that I've championed as the co-chair of the Diabetes Caucus, and many, many other healthcare bills and other bills negotiated as a package and then just abruptly stripped out of the continuing resolution when Elon Musk said he didn't want to do it. So we've been really pushing to, and he said this, we've been really pushing to have this bill come up on the floor. It was agreed upon, it was negotiated, and it's going to impact millions of Americans. It could come up, as he said, it could come up on the floor on the suspension calendar, and it would pass overwhelmingly. So we're hoping that that can happen. In the meantime, I don't really understand the decision just to pick and choose some of those bills, but I think people will look at them on their merits and decide. I don't think they're going to hold good legislation hostage, and don't always let the good be the enemy of the perfect.
But how exactly have these changes and these firings are going to impact your negotiations with Republicans and even the drafting of legislation where, like 21st Century Cures is a great example where added a lot of funding, new programs and everything, but now it seems like, are you operating under a new paradigm? Is there a new world order, I suppose?
I'm really hoping that my Republican colleagues will finally see what's going on here and will pull back their power, and that we can work together. I mean, I hope we can get the secretary in to testify, and I would hope that I just heard that next week it looks like the Senate is trying to, on a bipartisan basis, going to try to have him come in and testify. I would hope that my committee would do that too, and I would hope we would really take back these issues in a bipartisan way, because it's really important that we move forward on healthcare policy, not stay frozen, and certainly not make it a partisan fight. At the end of the last Congress, I developed Cures 2.1, advancing the goals of 21st Century Cures, with then Congressman Larry Bouchon. And Congressman Bouchon, of course, he retired, but we put together a white paper before he left. And I've been working on recruiting a Republican co-sponsor. I have many possibilities. I work quite well with many of the senior Republicans on energy and commerce, but all of this has been put on hold, just like everything else, until we get through this chaos.
So speaking of things being put on hold but that are going to be coming up soon is the issue of the Obamacare enhanced tax credits, which are going to expire after 2025 unless Congress does something to extend them. Have you had any chats with your Republican colleagues about a bipartisan deal on this issue?
So this is interesting because this is all taken up in the whole issue of Medicaid. And my constituents in Denver, Colorado, it used to be that people saw sort of different buckets for health care financing. You know, you had private insurance, or you had Medicare, or you were poor, elderly, or sick, and you had Medicaid. Now everything has been blended because of these tax credits under the Affordable Care Act and the extensions after COVID and all this. And so my constituents just see this all as part of their health care. And so if we let those tax credits expire, then millions of Americans will suddenly see their insurance costs rise dramatically. And I think, and they're going to see this as part of this whole debate around Medicaid. Now, over 70% of Americans support Medicaid, which we're seeing in this fight that we're having over the budget reconciliation bill, and the tax cuts for billionaires that Elon Musk and Donald Trump are pushing. But in fact, the American citizens are just going to see this as part of the whole Medicaid issue. So I think this debate is going to continue to happen throughout the year as we debate the Medicaid cuts.
Have you talked, though, with any of your Republican colleagues about, because there's likely going to be some type of deal. Republicans, I don't think were big fans of the Affordable Care Act. Have there been any conversations?
I have noticed that myself.
Have there been any conversations yet about this? Or?
Well, I think that my colleagues now recognize that the Affordable Care Act is here to stay. But I think you'd have to ask them what their opinion is of the tax extension, because I have not asked them about that specific issue. But all I know is, as the debate continues, is Americans now don't see this as should we have the ACA or not. They see this as this is in part how I'm getting my health care. And of course, everybody here knows health care costs are continuing to rise. We can have a long conversation about that another day.
Yes.
But as health care continues to rise, as premiums and copays continue to rise, then my constituents just see this as all part of a package. So if the Republicans try to cut Medicaid as part of a reconciliation package, and then they try to eliminate these tax credits, and if they start talking about other Social Security and other things, I think that's going to be really politically difficult.
That's a good segue, I think, into my next question about Medicaid. And of course, the Energy and Commerce Committee, which you sit on, is searching for about $880 billion in savings for the larger reconciliation package. Is there any way that your Republican colleagues can get to that number without touching Medicaid, as they have said that they're going to try to do?
The short and accurate answer is no. And the reason is because we were directed in the budget resolution, the Energy and Commerce Committee was directed to find $880 billion in savings, coincidentally, just the amount of Medicaid over the next 10 years. But then when we said, whoa, we would have to cut Medicaid to do this, they said, we never said the word Medicaid. We can do it in other things in the Energy and Commerce Committee. And of course, as you know, the Energy and Commerce Committee has very, very broad jurisdiction. So we started looking at, well, where else could we cut? We cut broadband, or could we cut spectrum, or could maybe EPA or anything? Well, we realized all the rest of the spending in Energy and Commerce Committee, total, all the rest of it, $500 billion. So if you zeroed out everything else that we do, you'd still be $330 billion short. This is why it is inaccurate to say that we can find other places to cut, because we just simply don't have that much money.
Some of the issue has focused on concerns among Republicans surrounding kind of the state's use of federal funding. Republicans have been kind of angry about issues surrounding provider taxes. They believe that states are using a loophole to tax providers in order to get a higher federal share of money, and then make providers whole through higher payment rates. There's been some talk about trying to get savings through that, get savings through addressing state-directed payments. What are your thoughts on kind of going after what your Republican colleagues say is a money laundering move by states?
Well, so I'm sure the states would beg to differ with that characterization. However, if the Republicans actually want to look and see if there are illegal activities or money laundering by the states, they should have a hearing on that. But mainly what they want to do is find an excuse to cut the Medicaid funds that go to the states, with the thought that states could just make up the difference. And a lot of people have said to me, of course, this is going to hurt the red states the most because they won't raise the money, but it's also going to hurt blue states like Colorado and California, where we have constitutional amendments that say you can't deficit spend. And already in Colorado, one of our biggest budget items, I think the biggest budget item in the Colorado budget is the state Medicaid match. And so if you cut Medicaid to the states, no matter what you label it as, then the states aren't going to be able to make up that difference. Colorado itself has a $1.2 billion deficit this year that they're going to have to make up. So also, if you make these adjustments to the states, even if you added a work requirement, which most experts say won't work, you still don't get up to $880 billion in saving. You can't get to that number without cutting large swaths of recipients off of Medicaid, period.
So I want to know, what tools do you have to kind of halt the actions that have been happening, like the cuts at the agencies? And, there's been a lot of anger that has been spilling out into hearings. Do you think that is going to continue, or what other strategy are you going to employ?
Well, I think that sunlight is the best disinfectant always, and I think that in the U.S. House of Representatives, the party that's in the majority, even if they're in the majority by 2 or 3 votes, it has complete control over the agenda, and so I can't make Secretary Kennedy come in and testify, even though I think he should. But what I can do is communicate with my constituents and talk to them about what's going on. Last Saturday in Denver, I had a Medicaid listening session wherein I invited patients, providers, and others to come and talk about what Medicaid means to them and what would happen if it was cut. And I got some incredible stories from those folks that I'm going to continue to push out there. So I think, and that's what we've been doing in the hearings too. We had a hearing on fentanyl, and so we took the opportunity to ask the experts who were testifying what would happen if people lost their Medicaid in terms of drug treatment and prevention, and they all said, well, it would hurt. And so I think the truth coming out is the best thing we can do.
So,
also, P.S., the elections last night showed people should be very, very worried about just trying to jam things through that are going to impact Americans.
So Senator Cory Booker, and I'll get you out on this, Senator Cory Booker broke the record for the longest filibuster, I believe, yesterday. There is another record, I believe, for Energy and Commerce of a 27-hour markup during the previous Obamacare repeal fight. Are you all gonna?
I was there.
Yeah. Are you all going to be going for that record?
That suit away.
Are you going to be going for that record potentially?
I don't. I mean, I think that communicating with people about what's going on is really important. And so whatever tools are the most effective at that time, that's what we're going to do. I was there last night when Senator Booker broke the record, and it was powerful because he was talking about how these policies are going to impact everyday Americans. And I mean, I've known you, and I've been around a long time. I'm one of the most bipartisan people in Congress. It's really hard to get me this angry, and the reason I'm this angry is because I think millions of Americans could lose their health care and potentially could lose their lives. And so that's what motivates me.
All right, well, thank you so much. Thank you, Congresswoman, for speaking with us today, and we appreciate your time.
Thank you.
Thank you.
Appreciate it.
Please welcome Politico's Executive Vice President and General Manager, Professional Business, North America, Rachel Leffler, and Adtalem Global Education's Chairman and CEO, Steve Beard.
Thank you.
Good morning, everyone, and thanks for joining us. As you heard, my name is Rachel Leffler. I'm the Executive Vice President and General Manager of our professional business at Politico. And I'm just so happy to have here with us today Steve Beard, who's the Chairman and Chief Executive Officer of Adtalem Global Education. Welcome.
Thank you.
Adtalem is actively addressing America's critical healthcare workforce shortage, in part by expanding access to quality education. We talked a little bit about this backstage. With a projected shortage of nearly 1 million critical care workers by 2032, Adtalem's mission to educate the next generation of healthcare professionals is a public health imperative. Given the looming shortage, I'm really eager to learn how Adtalem is navigating this challenge and ensuring students graduate as practice-ready clinicians. So we have a lot to cover today.
Sure.
So let's dive right in. Steve, with the recent executive order aimed at dismantling the Department of Education, what are Adtalem's key strategies for navigating this shift? How are you ensuring continued support for faculty, staff, and students?
Sure. So we're serving over 90,000 students currently across 5 institutions, all with a center of gravity in healthcare. So we're keenly interested in how these developments evolve at the Department of Education. But we are focused on working with the administration, working with the department to ensure no interruption in access to federal student aid, no interruption in support of the programs that we're rolling out to meet these workforce challenges in healthcare. And we have every reason to believe that our students, our faculty, and our community will be fine. We respect the administration's perspectives on what they'd like to do with the department, and we look forward to partnering with them because we think our workforce agenda and our healthcare agenda is completely aligned with the administration's agenda.
Terrific. So we're facing a potential shortage of healthcare workers, and baby boomers are projected to live longer and require more care than past generations. What will be the impact here? Is our healthcare system at a tipping point?
I think so. I think the current dynamic with growing demand and shrinking supply isn't sustainable over the long term. I think technology will play a role in relieving workers from administrative tasks that consume their time, but it'll be no substitute for the need to bring more supply to U.S. healthcare. And as the largest educator of physicians, nurses, social workers, and veterinarians in the United States, we think we're well positioned to help address that. Part of the way we do it is actually by expanding access to those careers. There's a ton of scarcity across these programs in the United States today. In addition, those programs aren't exactly flexible and accessible and friendly to students who need to go to school at night or on weekends, who are coming to their academic journeys later in life, who are changing careers. And one of the things we focus on is bringing accessible, flexible programs to students to allow a different profile of student to pursue these careers, which by definition grows the supply of clinicians that we all depend on.
And I'm going to take you up on your offer to go to one of the graduations we were talking about because it sounds extremely inspiring. So as one of the leading providers of healthcare education, your focus is on increasing the talent pipeline. What's different about Adtalem's approach to this problem?
Yeah, so we've got 3 attributes that I think make us unique. The first is our scale. Again, over 90,000 students on any given day. We're serving about 42,000 nursing students. The other attribute is the flexibility. We allow students to pursue their programs virtually, campus-based, hybrid-based programs. But just as importantly, because we're serving what used to be referred to as the non-traditional student, that by definition is an extremely diverse community of learners. And as a result, we're able to produce more diverse clinicians than just about anyone else in the United States. So more Black physicians than anyone in the United States, more Latino physicians than anyone in the United States. We serve a number of students for whom English wasn't the language they spoke at home growing up. And as a result, these folks come to the art and science of healthcare with a real affinity for the diverse population of patients that they're going to be asked to serve.
No, that's very interesting. And so building on that, you're working on not only ensuring there's an adequate number of healthcare professionals, but also that they provide culturally competent care. And I think that's what you were starting to sort of refer to.
Sure.
So tell us why you believe broadening that pipeline and who has access to medical schools is not only helps with stability, but also improves outcomes.
Yeah, I think the research on social determinants of health, health inequities is well accepted, that people receive more compassionate and more competent care from folks with whom they can develop a relationship of trust, and very often those relationships are built on mutual affinity, right? And as an African American whose community is historically suspicious of healthcare, going into a clinic or a hospital and having someone understand your background, your culture, your diet, the way you celebrate, goes a long way towards ensuring that those folks are getting the kind of care that they need. So we're just really proud to be able to bring that kind of diversity to the profession that stands to change the face of healthcare in a way that benefits all of us.
Mm-hmm. Mm-hmm. So turning now to another conversation that we had backstage, a little bit about AI. Yeah. Students and faculty support needs continue to change, and so especially with the rapid developments in technology. How is Adtalem keeping pulse on technological innovations and incorporating them into the classroom?
Yeah, so we've been talking about the extent to which technology will disrupt education for 25 or 30 years. It hasn't really happened in a meaningful way, but I do think artificial intelligence, generative AI, is different. And I think we're on the cusp of something that will dramatically change the way students consume content, dramatically change the way we support them in their academic journeys, and we're experimenting with any number of innovations around that currently. So we've got AI tutors that support our students. We're doing student advising and counseling with AI agents that are available to them 24/7. We're able to develop proprietary large language models that can take all of the academic content in a given program and make it accessible to students in a way that provides an adaptive learning experience. And in addition, we're partnering with folks who we think are on the cutting edge of these technologies in ways that will support clinicians in the workplace. So, for example, we recently launched a partnership with Hippocratic AI to develop a curricula for using their tools in care delivery and developing the first ever AI certification for clinicians. And we're really excited about what that portends for clinicians and what we're learning from the folks at Hippocratic about all the ways in which artificial intelligence can address some of the scarcity, particularly in population health.
Hippocratic AI, interesting. Yeah. Last question for you.
Of course.
There's a lot of people in the audience today, some of whom are healthcare policymakers. What is one takeaway from Adtalem's work that you hope they keep in mind or could spur action on this issue?
Yeah, I think what I want to leave folks with is that we often think about these professions, medicine, veterinary medicine, nursing, in the prism of this idea of higher education as being driven by high selectivity and prestige. And I think that's incredibly valuable. But if we're going to solve these workforce challenges at scale, we're also going to have to think about alternative pathways into these professions for which selectivity and prestige just aren't really helpful attributes. And anything policymakers can do to both incentivize students to pursue these professions, to make it easier for them to get into these fields is welcome. And also anything that policymakers can do to ensure that the industry groups that represent these professionals are open to the fact that while scarcity is valuable to them in the short term, it presents real challenges for quality of life and the rewards of these professions if not addressed thoughtfully. And we stand ready to partner with policymakers to make that happen.
Fantastic. Thank you. That is all the time we have today, but I really want to thank you, Steve, Chairman and CEO of Adtalem Global Education, for your time, your inspiration, and your smarts.
Thank you. Thank you for the time.
Hi, everyone, again. I'm going to ask you to bear with me for a second because I have lots of information for you. Excuse me. Okay, so as I mentioned at the top of the show, we're going to offer you all an opportunity now to get up, get food, check your email, network, get to know your neighbor. If you are a pro subscriber, you have been invited to 2 special breakout sessions. The first one with Dr. Ben Carson and Stanley Goldfarb on health equity. That will take place in the McPherson room right outside where you walked in. The other is on payment reform with former CMS Legislation Director Emily Felder and former GOP Doctors Caucus member Larry Bouchon. That is out in Farragut Square, which is also right outside. I also would like to highlight that we have a very special Politico Pro Genius Bar for pro subscribers and for all of you who are now having FOMO and are pro curious, we want to meet you. Our Genius Bar is out where you checked in and has, wait for it, 4 fun things. Free swag. Everybody wants free swag. You can also get set up on a free trial of our Pro service and Agency IQ, where you can get exclusive coverage and analysis on healthcare. You can also enter a free raffle to win an original cartoon by Politico's Pulitzer Prize winning cartoonist. And we can generate a free custom report on any policy topic you care about. So that's all happening right outside. But there's also still more, guys. Still coming up after that, we still have a conversation with Senator Maggie Hassan of the Senate Help Committee, Dr. Bruce Scott, President of the American Medical Association, Dr. Scott Gottlieb, former Commissioner of the FDA, a panel on AI and healthcare, and 2 conversations on public health with Dr. Vanessa Carey and Dr. Atul Gawande. So I want you all to get up, relax, attend your sessions, come back and meet me here. And one more shout out and thank you to our sponsors, PCMA, the Joint Commission, Walgreens, Hackensack, and Adtalem. I will see you all back here with me in 30 minutes. Thank you.
Please take your seats. The program will begin shortly. Welcome to Politico's Healthcare Summit. Please welcome Politico's executive producer of events, Annie Allen.
Hi again. Thank you guys for coming back. I hope you all enjoyed your break, your breakout sessions, and all that. So as we talked about before, we have a great lineup for the rest of the day. We had a spicy morning. First half of the day. So who knows what's going to happen over the next couple of hours. But first up, I'd like you all to help me out. So the next conversation is going to be between Patrick Conway, the CEO of Optum Rx, and my boss, Callie Bowdy. So I'd like you to give a huge round of applause and be ready for that. So thank you.
Please welcome Politico's Executive Vice President and General Manager, Media Business, Callie Bowty, and Optum Rx CEO, Patrick Conway.
Hi, everyone. Thank you so much. I'm the second Callie to take the stage today, which is a rarity here, but I'm thrilled to be with you. As the voice of God just said, I'm Executive Vice President and General Manager. And before our next panel takes the stage, I'd like to begin by thanking our sponsor, PCMA, for their support in today's summit. In partnership with PCMA, I'm delighted to sit down with the CEO of Optum Rx, Dr. Patrick Conway, to discuss PBMs and what may lie ahead for the future of PBM legislation and reform. Patrick, thank you so much for joining me.
Thanks. Great to be here.
So as we've heard so far this morning, healthcare policy is top of mind for legislators, and PBM reform is on the table. So as the CEO of a major healthcare company running one of the largest PBMs, I'm sure the audience is very eager to hear you weigh in on that conversation. So why do you think PBMs are such a central focus in a lot of these discussions, and what's missing from the conversation?
Yeah, so thanks for having me, and thanks for all of you for being here. I'd call out a couple things that are missing. I think we need to focus on the facts and what we can agree on. So I think we could all agree that we want drugs in this country to be more affordable. Innovation that doesn't get to patients doesn't benefit them. It's useless. So we need drugs to be affordable, get to the patients who need them. As you mentioned, I'm a physician. I'm still a practicing physician on weekends, and we may talk about that occasionally during the conversation today. So I see it in real time, that importance. When you think about Optum Rx, I've been in the role about 20 months. About 2 months in, I was with the team, and I said, guys, I think what we do is we serve over 62 million people, over 1.6 billion prescriptions, and if we get the right medicine to the right patient at the right time, affordably, that's what the system needs. That will drive growth. It'll drive better health outcomes, et cetera. So that's what we do at the core. About half of our business is PBM. About half is the pharmacy services. Now let's talk about sort of the facts and sort of some of the underlying things and what we're trying to do about it. If you look at list prices in the U.S., they're too high. List prices are set by pharmaceutical manufacturers. So that is the nature of the market. I worked in government twice. If you think about Medicare, Medicare sets prices for hospitals, physicians, nursing homes. There's an area where Medicare is a price taker. It's pharmaceuticals. So in this country, that's how the system has worked. Pharma companies set the list prices. Those are often about 10x other countries. Then what do we try to do about that? We negotiate rebates or discounts, about $48 billion last year. And we announced recently in January that we're going to pass on 100% of those rebates, those discounts, to our customers. So we serve over 5,000 employers, unions, governments, others across the country. We're the only large PBM to do this. To be clear, because I heard there was a question about this earlier, we allow people to audit it and are transparent about it, that we're passing on 100% of the rebates to customers. Next major change that we announced was in prior auth and reauthorization, which I'm sure you hear a lot about in D.C. We actually did a review and removed 25% of reauthorizations, which is over 10% of total prior authorizations. And these are drugs that clinically you said you no longer need to do this. So removing that from the system, making it simpler. The other thing we're doing in prior auth I'm excited about, I was actually on a panel a couple of days ago about this, we're pulling information from the clinical record and making prior auth, which used to take on average over 8 hours, less than 30 seconds for approval. So you're that physician, you're that prescriber, and it's approved in real time. The third major change I'd call out that is an important focus area for us, and I think should be more broadly, we announced cost-based reimbursement for pharmacies. So you've probably heard in D.C. from independent and community pharmacists who say, I'm not being paid fairly for drugs. What's gone on historically is we underpaid the whole industry for brands and overpaid for generics. That probably made sense when you wanted to drive generic usage. We're now we've been maxed out on sort of generic usage for many years now. And it's a real issue, GLP-1s. I've had pharmacists tell me I'm losing money dispensing these drugs. We announced we're going to pay cost-based reimbursement for 100% of pharmacies, 100% of drugs, and 100% of clients, and rolling that out over the next 3 years. There's no entity that has done that at that scale. People will have, and we did as well, smaller cost-based programs for some drugs or some clients or some pharmacies. This is across the whole system. So we're really trying to lead in a market-based way to drive a better health system for everyone.
So let's stick with the drug pricing specifically, which has been a major topic on the Hill and across the country overall. So you just mentioned a couple things that Optum Rx is doing, but how is the PBM industry thinking about addressing affordability writ large, you think? Yeah, so I'm going to start with a patient story here and then give some examples. So I shared this at an investor conference one year. Early in my training, I work as a pediatric hospital medicine physician, still do. But I discharged a child who had an infection, 2-year-old, and their family, and wrote the antibiotic prescription like you do. Family came back into the ER, very sick, septic. Luckily, that child did well. But I asked the mom, what happened? And she said, well, I went to the pharmacy and it was $200. And I didn't have $200, so I was going around trying to find $200. And then my kid got sick, so I brought him back to the ER. That's horrible for the family. It's horrible for the system. We should prevent that. So that gets to what we do on affordability. I'd call out 3 different programs. One is called Savings IQ. We basically, in the specialty medicine arena, so these are very high-cost drugs. Once again, list price set by the manufacturer.
We built a tool that finds support programs from us, from manufacturers, anywhere that exist, to lower the copay, lower the amount the consumer pays. Last year, this saved $1.3 billion out for consumers, so direct money savings for consumers, $1.3 billion. The median copay for specialty drugs, these are really high costs, went to $5, and the average copay for cancer went down 88%. I got an email a month or two ago from a person we serve who was honest. He was on a cancer medicine. He'd been going on and off, and he hadn't been telling his wife. And now he could afford the medicine and stay on. That's better for the system. It's better for him. You know, it's what you'd want. Quickly, because I know you always have limited time, call out two others. We started a program a few years ago called Critical Drug Affordability, but it's for like diabetes, asthma, various things where it's clear people should be on their medicine. And we made the copay $5, so low copay. Drives better adherence, keeps people on their medicine. You know, another example, and we you know, it's spreading across our client base, so it drives adherence. You know, home delivery, our adherence is 30+% better than other areas. The last one I'll call out is called Price Edge. So we built a tool that literally looks for the lowest cost at the point of sale. About 90% of the time it's with insurance, but about 10% of the time it's cash. So we tell the consumer. We have over 10 million people on the tool today. On average, it saves $50 per script, and it saved over $220 million last year, once again, back to consumers so that they can afford their medicine. So bring it back to what we should agree on. And I worked in government twice. I know it's hard in D.C. to agree sometimes, but I think we should agree affordable medicines that get to the people who need them. Those are the kind of solutions we need.
What do you see for PBMs ahead for the next 5 to 10 years?
Yeah, I love that question. I was on the Hill yesterday. I won't name the senator, but we've interacted for many, many years, and we were talking about this a bit as well. First, I don't think of us as a PBM at OptumRx. So what we talk about as a team is we're a pharmacy care services organization. In fact, about half of our business now is the pharmacy side, and it's growing. And it really, what we do, we administer benefits, but what we really do is we deliver medicines to people, like I said. Whether it's specialty medicines, we do rare and cell gene therapy, we do infusion in people's homes and outpatient sites. We do mail order. We're getting medicines to people. So we're a pharmacy care services organization. Then what do I think happens with that? I'd call it a few things. Biosimilar adoption for us and others, I think, is going up. We're driving 20 to 50% year-over-year savings for our clients. You know, typically $0 copay for patients. So I think that's one trend to watch. Rare and cell gene therapy. The pipeline, those drugs are coming. And I don't think as a nation we've figured out how to pay for that pipeline of drugs. A lot of this goes back to the list price set by manufacturers. But how do we support? You know, I took care of children with cystic fibrosis, spinal muscular atrophy, sickle cell. These were deadly diseases that now we can cure. We need to get those therapies to people. To get those therapies to people, they have to be affordable. And so that's the core issue we have to tackle in rare and cell gene. You know, the other trend I'll just call out is consumer-directed care. I mean, you heard it in some of the tools I talked about. At the end of the day, we need transparency, choice, and affordability to our clients, employers, you know, payers, governments, et cetera, but ultimately all the way down to that consumer. So that mother that I mentioned, you know, this was many years ago now, but what you'd want for her now, and I still discharge kids from the hospital. I work at a safety net institution, that when they go to the pharmacy, they can fill that medicine, they can get it affordably, they can take it, and they get the better health outcomes at a lower cost that we would all want. That's what we want for the system.
Patrick, while I know we just barely scratched the surface here, unfortunately that's all the time we have, but we appreciate your time and insights, and thank you again to PCMA for your support of today's summit.
Thank you. Thanks for having me.
Thank you.
Hi, everyone, and welcome. My name is Kelly Hooper. I'm a healthcare reporter at Politico, and joining me for a conversation today is Dr. Bruce Scott, the president of the American Medical Association. Dr. Scott, I have to start out by asking you about a comment made by Callie Means during his panel here just a few hours ago. He said the Centers for Medicare and Medicaid Services is being controlled by the American Medical Association. So I wanted to hear your response to that.
Well, I guess I would say I wish. There's a few things we would change, many of which we're going to be chatting about. I want to thank you for the opportunity to be here and thank Politico for sponsoring. This is a great opportunity. It's interesting to me that we're talking about healthcare, and I think I'm the only physician who's actually practicing who's on the agenda today. And maybe that's part of the problem, that we need to get back to letting physicians actually be in control of our healthcare.
What do you think he meant by that CMS is being controlled by the AMA?
Oh, I think that it's a misunderstanding. I would say, also for the record, that the American Medical Association does not receive funding from the pharmaceutical industry. In fact, we have disavowed funding from the pharmaceutical industry for many, many years. I think the important thing is that there are some things we agree about, and I think that's what we need to work with the administration on. To be clear, we need to address chronic disease. We need to address nutritional issues. We all want children to be healthy. We want adults to be healthy. We want our parents to be healthy. And I think that what we are looking for is to work with the administration, including Kennedy, about the different things that we can do to improve health care in America.
Do you think there's merit to the argument that there needs to be more of a focus on the prevention of disease rather than treating sickness as the standard of care, as Means and Secretary Kennedy and others have suggested?
I think that there does need to be an emphasis on prevention. I think we've already seen some of the stuff from the Affordable Care Act has started to cover preventive care, and I think that's really important. And I think that there's already an emphasis on that. That said, I'm a surgeon. And so one of the things that we have to do is take care of the acute problems that exist right now. So we can't have a slash and burn technique. We need to focus on the current problems, but at the same time, we do need to emphasize preventive care. Some of the things that the American Medical Association has been pushing for years does emphasize preventive care.
Something that HHS Secretary Kennedy has expressed some interest in is Medicare payment reform, including targeting the AMA's role in setting relative value units, which is a metric that can help determine how much Medicare pays for certain services. Does that concern you at all? And could you talk about what that would mean for the AMA if the organization had less of a role in the decision-making process around doctor payments?
The big thing that concerns the American Medical Association, and frankly physicians all across America, is the 33% pay cut that Medicare has forced upon physicians over the last 24 years. Believe it or not, physicians are paid 33% less for the same services that we were providing in 2001. Imagine those of you who have companies here, if you were being asked to provide the same services 24 years later with the inflation that we've all lived with 33% less revenue coming into your company to my practice. And as a result, physicians are struggling. As I travel around the United States, I talk to physicians and I hear the stories. I hear the stories of them reducing the number of Medicare patients they're able to see, stopping taking new Medicare patients, reducing their staff, not investing in new technology, and sadly, in a lot of areas, closing their practice altogether. And particularly, I'm from Kentucky, a rural state, and in Kentucky and other rural states and where there's underserved population, when a physician closes their doors, the access to care for those patients is just terribly harmed. In some cases, 100-mile-plus drive to find a physician, if you can even find a physician who's taking new patients. And the frustrating thing is these are our most vulnerable patients, our senior citizens, our people who have permanent disability, the people who are less able, in many cases, to find a new doctor and to get new access. So that's what we're really focused on and really concerned about, and we're looking for a rollback. But believe it or not, we're up here in Washington spreading that message in 2024, and yet we got another cut, another 2.8% cut starting January 1st, 2025, despite the fact that CMS, which we don't control, predicted that our cost of providing care would actually go up 3.5%. So if you think about it, it's unsustainable. It can't have continued cost with lowered what they're paying us to our practices just to keep up with the cost of providing the care. At the end, physicians are struggling, and I really fear for access to care for our senior citizens.
Speaking to the funding cut, so a funding bill passed the House earlier this month or earlier last month that will allow a 2.8% cut in funding to physician payments. You've been vocal about these cuts, as you were just speaking about, and about how they will affect private doctor practices. How do you think the payment formula can be improved upon?
Well, pretty simply, the payment formula for physicians needs to be linked to the cost of providing care. Now, here's the really crazy thing. Hospitals, ambulatory surgery centers, long-term care facilities, basically everybody else in Medicare already gets an inflation-based update, but not physicians. How does that make any sense? Physicians are the foundation of healthcare, and yet we don't get the update. And I guess the thing that I would say to our legislators is every time there's an election, we hear our legislators say, I'm going to protect Medicare. I'm not going to let Medicare get cut. But yet they continue to allow the payment to the physicians to get cut. If there are no physicians to provide care, how is there Medicare? It just doesn't make any sense.
Republican Congressman Greg Murphy has said that he received assurances that Republican leaders would consider stopping the doctor pay cut in the budget reconciliation bill. How confident are you in those assurances, and are you hopeful that there's still a chance to avert the cut sometime this year?
I'm hopeful that there's still a chance. I'm nervous about the prospects because we heard similar things December the 15th. I was here on the Hill, and we had bipartisan support for a specific piece of legislation that would roll back the 2.83% cut and actually begin to link the cost of care to the payment. And that was left on the cutting room floor. Then we were told during the continuing resolution discussion that we were in there, and really appreciate Representative Murphy, his work, and the others in the Doc Caucus who all really were champions on this issue, and we thought we were going to get a fix. And then it got cut again. And I think a lot of the reason for it getting cut was not because there's not bipartisan agreement, because I think there really is, but because of a desire to keep the packages skinny, if you will. And I think that now it's time for us to push forward with what is right, that physicians in America who are struggling to take care of the Medicare patients basically need a cost of living increase, which they haven't gotten in 24 years.
Do you think there will be, appetite among Republicans to address the issue, just given how costly it is, and, especially that they might not want to add more costs to the reconciliation bill, and sort of where does that leave you on the issue?
Well, we do have, as I said, bipartisan support. We have Republicans on that side who are very much champions for us. We have Democrats as well. This really is bipartisan. I think that's what makes it hopeful for me. I recognize that there's a cost. There's a line item cost of passing this legislation, but I guess what I would answer back is, what's the cost of not fixing this? We have a projected shortage of 86,000 physicians in 10 years. We already have a shortage of physicians. There are hundreds of counties in the United States that have no obstetrician, no primary care doctor, where the nearest physician in a specialty is 100+ miles away. It takes 8 to 10 years to train a new physician. And so if we don't address this problem today, we're not going to be in good position in 8 to 10 years from now when we're facing that shortage to address the problem at that time. So I'm hopeful that they'll see the light. It's interesting that every person in the House and in the Senate who has a medical background supports this legislation. So CMS supports this. The Medicare trustees support this. MedPAC now supports this. It's time for the rest of the legislators to listen to people who are knowledgeable about the system and recognize that change needs to occur.
If Congress is to act, it would most likely be a short-term fix. So what do you think longer term, what needs to change to address some of the structural issues with doctor pay?
Well, we need to roll back this 2.83% cut right now. That was in the legislation both for the continuing resolution and at the end of the year. But then we need this longer-term fix. Physicians need to know that there is sustainability, that medical students need to know that there is a future. There was a study done of second-year medical students that 40% of them said they probably never intended to practice clinical practice because of the challenges that they're seeing within medicine. Now imagine that. A shortage of physicians, and yet almost 50% of medical students are saying, whoa, wait a second. That's why we need this long-term fix. And that's what we're really pushing for. This isn't some radical idea. It basically puts physicians on par with all the rest of the providers, from the hospitals to long-term care facilities to everyone else who takes Medicare. It makes sense to put the physicians on that same platform of giving us something for the future that we know we can look to and say it will be sustainable and I'll be able to keep my practice alive.
Just switching gears a little bit, I wanted to ask you about the sweeping cuts that GOP lawmakers are considering to Medicaid, potentially putting health coverage for millions of people at risk. We've seen hospitals, provider groups, insurers, advocacy groups speak out against these cuts and push Congress to protect Medicaid. What is the AMA's stance on the cuts that Congress is considering?
The AMA is very concerned about the degree of the cuts. Let's be clear, we're okay with reductions of fraud and abuse and those sort of waste, but we have serious concerns about the degree of cuts that are being talked about. The understanding is very clear. We know that people who do not have health care coverage live sicker and die earlier. And that's wrong. In a country with the resources that we have, we need to make sure that, and if you examine the actual cost over the long term, it is so much better to get people care when they need it in a primary care doctor's office, in the regular physician's office, rather than what they reach out to, emergency rooms, urgent care facilities. They go into the doctor once they're desperate, once the cancer is no longer a stage 1, easily and relatively inexpensively treating. Instead, they go when they're in a disaster, when it's a stage 4 cancer. I see this in head and neck throat cancer. I see this in patients who don't have the resources, who don't believe that they can get the care. They delay care, and that delay of care ultimately costs more money. So we're deeply concerned.
In 2017, the AMA was very vocally against Republicans' attempt to repeal the ACA. And the group was specifically opposed to caps on federal Medicaid spending, which is being floated by some Republicans in Congress now. Can we expect to see a similar push against those proposals from the AMA this time around?
Well, we haven't seen a specific proposal, but the proposals that are being chatted about, again, we have deep concerns about a number of those. We think that the expansion of Medicaid in the states that have chosen to expand it has proven to be a very good thing for our health. So anything that would roll it back would be of concern.
And I think we have time for maybe one more question on a totally different topic, but one that seems to be top of mind for doctors, which is the increasing use of artificial intelligence in healthcare. Where do you see room for improvement in the federal regulation of AI in healthcare, and what do you want to see more of from the federal government on this topic?
You know, physicians are excited about the potential AI. We like to call AI augmented intelligence rather than artificial, in order to emphasize the role of the physician. AI will never replace your physician. That is not going to happen. We need that human touch, the human feeling, which is so much a part of healthcare. And yes, regulation needs to be put in. I will tell you that in a survey the AMA did, physicians are equally excited and equally terrified about AI. And one of the things that we've seen early happen is insurance companies utilizing AI to deny more and more care. So that's not the reform we're looking for prior authorization, not the ability to more rapidly deny and delay needed care. That's one example of where AI has turned sinister. On the other hand, physicians right now spend about 2 hours on administrative care for every 1 hour of taking care of patients. And if we could reduce that burden of administrative care, documentation, and some of the other things that we need to do by use of AI, then it's wonderful and physicians will embrace that.
What's the right vehicle to get that done?
Oh, I think that there's so much investigation and innovation happening out there. We just need to make sure that we keep our eye on the ball, that the goal in everything is to take care of the patient, that the patient needs to remain the center focus of our care.
I think that's all we have time for today. Thank you so much, Dr. Scott, for speaking with us. We really appreciate your time. And next up, we have Senator Maggie Hassan, who will be speaking with Politico's Aaron Shoemaker.
Thank you.
Hi, everyone. I'm Erin Shoemaker, National Institutes of Health reporter at Politico. I am joined today by New Hampshire Senator Maggie Hassan, who sits on the Senate Health, Education, Labor, and Pensions Committee and serves as a ranking member of the Joint Economic Committee. We are here to talk about the threat of Medicaid cuts, the sweeping overhauls we saw yesterday at federal health agencies, and what these changes mean for your constituents in New Hampshire. Welcome, Senator. Thanks so much for being here today.
Thanks for having me. I really appreciate it.
Of course. Senator, I want to start with these mass layoffs and sweeping overhauls at the health agencies, which really shook Washington yesterday. What can you tell me about Democrats? Are there any tools in Congress that they can use to fight these cuts?
Well, let's just start with how devastating and chaotic these reductions are. Literally, employees arriving at regional offices yesterday and their badges just didn't work. No notice first. This is not only chaotic for the employees, it's a huge disruption to our healthcare system and to our public health system and to our systems that take care of children. Some of the people who couldn't access their buildings are folks from the Administration of Children and Families. They're the ones who support Head Start, for instance. So this is another demonstration of just how chaotic and disruptive and harmful the administration's actions are. We are certainly working to try to first get information about why and how these cuts are being implemented. We are trying to get information from the administration about what the plan forward is. But look, when I traveled to New Hampshire, just last week I met with a group of public health folks about the fact that the administration clawed back $80 million from New Hampshire that had been designated for public health services through the end of 2026. That means we are laying off public health nurses. That means we are having to close a mental health and addiction crisis line. I can go on and on with the kind of real impacts it has. At the end of the day, this also is really kind of a preview of what the Medicaid cuts that the Republicans are planning to make will do. It's going to decimate healthcare, ripping healthcare away from people just so that billionaires can get additional tax cuts.
So I do want to talk more about those potential Medicaid cuts. But in terms of tools, is there anything that Democrats can do besides collecting information, or once you have that information, what can you?
Well, we have an oversight function that, as you know, this administration has been ignoring, to put it politely. So we will try to exercise oversight. There are certainly, I am sure, legal actions that can be taken as well. But the stonewalling that we're seeing from this administration, again, with the desire to really dismantle our healthcare system, is really, really concerning. And as you know, Chair Cassidy and Ranking Member Sanders have asked Secretary Kennedy to come into our committee next week. That would be a first step in us deciding what tools we have, what actions we can take. I hope Secretary Kennedy will take us up on the invitation, because it's really, really a critical time. So many Americans, we're talking about tens of millions of Americans losing their health care because of the Republican budget proposals, but also because of the actions that this administration is taking.
We'll be looking to hear more on that for sure. Are there any places where Republicans and Democrats can work together on this? What do you think?
Well, I think the fact that you're seeing the chair and ranking member invite Secretary Kennedy in is a reflection of the growing bipartisan concern on the Health Committee, on the Finance Committee. You mentioned too, Joint Economic Committee, where we're looking at the data about the impact of these cuts on the economy and on people. But look, we have some bipartisan bills, as you know, on everything from rural maternal and obstetric care to site-neutral payments. But those are only really, they're relevant and impactful only if we have a healthcare system that is essentially close to what we have now. And if we are talking about the kind of Medicaid cuts that we're seeing the Republicans propose, we're talking about undermining, for instance, maternal care in a way that makes a rural maternal health care bill less impactful, less relevant.
I want to turn for a second to New Hampshire and use that as a frame to look at these cuts. What are you hearing from constituents about the Trump administration, about the DOGE cuts, especially the health cuts? What are your constituents saying?
My constituents are really, really worried. So I'll just start with talking about the woman I brought to the President's Joint Address in March. She is a woman working in the private sector now who is in recovery from opioid addiction. Because Medicaid expansion exists in our state, it was a bipartisan effort to get that established in New Hampshire while I was governor. She was able to get treatment for her addiction. She is in recovery. She is working in the private sector now. She's on private health insurance. So all the things you want, we all want people to work. And she's acting as a peer recovery coach and really helping other people get into recovery. That is all at risk right now because, of course, New Hampshire is one of the trigger states. If federal funding for Medicaid expansion goes below 90%, we automatically eliminate Medicaid expansion, which, by the way, probably eliminates addiction treatment coverage for about 10,000 people in my state, eliminates care for about 30,000 kids, about 60,000 people overall if the Republicans go forward with it. Parents of a young man with autism who told me that their son gets his health care through Medicaid, they're very worried about their cuts. Going up to NIH, going up to Dartmouth Health, which receives NIH grants. It's one of the 57 cancer centers in the country, one of the few that's in a rural area. They have already seen layoffs and cuts that are impacting their capacity to do critical research that we are already invested in, right? So the administration is just wasting a critical amount of investment in critical life-saving medical research. And then we talked to a researcher up there, and some of this money goes to the medical school, Dartmouth Medical School. Some of it goes directly to the Cancer Center and to Dartmouth Health. But one of the researchers reported that she came down to Washington to present at a conference that was being sponsored by a sub-agency at HHS, only to be told she had to pre-submit her slides. She does research on mental health and addiction co-occurring among adolescents and teens, and they censored her slides. And I just want to say that again. This is the United States of America, and a scientist had her slides censored. She was not allowed to disaggregate her data by boys and girls. And they told her she couldn't use the term social determinants of health. So I am hearing from people who are worried about their actual care. I am hearing from people who are worried about the tax subsidies for the ACA being taken away, because that will be a huge cost increase for some of my constituents. And then I'm hearing from researchers who are investing in everything from mental health research to primary care research about cuts that are really tearing away critical care and life-saving treatment for my constituents. So the concerns are palpable, not just in healthcare, but everywhere.
So we have these palpable concerns. I mean, I've also been hearing from researchers about their funding being cut. We know that studies have been halted, trials, including on cancer. Things you've mentioned certainly dovetail with what I've been hearing. Even though, like in many cases, the money for that research has been appropriated by Congress, is there anything stopping President Trump from doing what he wants with that appropriated spending?
Well, many of us take the position that he is violating the Impoundment Control Act. many members of his administration during confirmation hearings, when I've asked them about the Impoundment Control Act, just basically say that they don't believe it's good law, and I've reminded them that the Supreme Court has held that it was constitutional, and that if they want to change the law, they need to come to Congress to do it. And there are obviously lawsuits that are proceeding that have in which the administration's been instructed to spend the money. But at the end of the day, these things take time. But we are pushing as hard as we can, as are the lawyers who are representing the interests of the recipients of these funds. This is a constitutional democracy that has relied historically on good faith, on people all believing that the democracy comes first and that we're all operating with the same set of rules. It is deeply concerning, of course, that this administration seems to think that they are operating in a different context. And it's something that we're continuing to speak up about. We're obviously the minority in both chambers. We need a handful of Republican senators and a handful of Republican House members to join with us in their commitment to the democracy and to their constituents. And that's where constituent voices and people speaking up make such a difference.
I do want to talk a second about strategy. I mean, New Hampshire's an interesting state. It's got this well-known sort of libertarian bent and a purple constituency. Yeah. Do you have a different strategy than any of your Democratic colleagues? Like, do you have to pick your battles in some way?
So for any of you who haven't been to New Hampshire, please come. It is the live free or die state for a reason. We were the first state to declare independence, and we were the 9th state to ratify the Constitution, which means we are responsible for creating the United States of America. Not that I would want to overstate anything. But look, we are a very special place. We also have a state house that includes a House of Representatives of 400 members, and we're 1.4 million people. And everybody works on a volunteer basis, and a state senate of 24 people. And then there's something called the Executive Council, which oversees the governor and approves every contract that the state enters into, for instance, of $10,000 or more. So we are a citizen-engaged democracy, and all I can tell you is that my constituents talk to me on a regular basis from all walks of life, from all political perspectives, which I believe is as it should be. And what they really want is, one, people who respect the Constitution and believe in democracy, and two, people who are problem solvers. And we are known for our libertarian streak, but also our bipartisanship. And the thing that I am focused on right now, I try to follow the example of my constituents every day in finding solutions, reaching across the aisle to do it. But to have true bipartisanship, you have to have a functioning democracy, because compromise happens when everybody at the table recognizes that each person negotiating has an equal say. And that is what is at risk right now. So I continue my commitment to bipartisanship, but I also know that in order for that to function, we have to have a democracy where the Senate and the House and every member is considered equally important because of who they represent.
I do want to circle back to that strategy question, but let's turn to Medicaid for a second. You're on the Finance Committee that oversees Medicaid and Medicare. House Republicans have proposed a budget that could significantly cut Medicaid funding. If that happened, what would the impact be on New Hampshire?
So what the Republicans have proposed in the House is a cut in the $800 billion range, about a third of Medicaid. And Medicaid, I mean, this is math, right? So the math is that if you're going to achieve those cuts, you either got to take away care from a third of the people or reduce what you're paying by a third. In my state, what this really means is that we are looking at, of the 180,000 people covered by Medicaid, 60,000 people would lose their coverage, 30,000 would be children, and obviously Medicaid covers, in my state, thousands of seniors, I think it's 15,000 kids with disabilities, and a lot of people who are working and who don't earn enough to afford private health care, or who are sick and want to return to work and need the health care in order to get back to work. About 10,000 people are covered for addiction care in New Hampshire by Medicaid expansion. So this would decimate, it would take away coverage for 1 in 5 people in our nursing homes. Nursing homes would close. It would decimate our rural hospitals. And as you know, about half of births in rural America are covered by Medicaid. So maybe half of births in all of America, but it's a significant portion, right? So the impact is unbelievably big, and people are really, really worried about it. And, you know, I feel like we are relitigating the argument we had when we passed the ACA and relitigating the argument that we had when we established Medicaid expansion in so many states. People don't stop getting sick because we don't pay for health care. And that's the ultimate fact here, that we finally came together and recognized. And as you make these kinds of cuts to Medicaid, as if we don't reauthorize and reappropriate for the ACA tax subsidies, what happens is more and more healthy people leave the market, and that drives everybody's prices up. So for an administration that says it wanted to lower people's costs, they are acting in a way that will do exactly the opposite. People will be sicker, healthcare will be more expensive if you can get it, and the workforce will be increasingly strained. And private insurance will be.
Is there anything Democrats can do to convince Republicans to extend those Obamacare?
Well, we are working, you know, we are making the arguments you are hearing right now, because just to give you an example, a couple, let's say they're 60 years old, so they're not eligible for Medicare, not yet. They're earning $80,000 a year, so a little bit over, you know, more than poverty, but not a lot of money given today's expenses, right? It would push, by our estimates, their health insurance costs up $800 a month if the subsidies go away. So we are making this case to our Republican colleagues. Again, they need to be willing to stand up to this administration. That's how a democracy is supposed to work.
Senator, you stood out to me during HHS Secretary Robert F. Kennedy's confirmation hearing as being a forceful questioner and making a really vigorous case for vaccines. But you were also one of the 3 Democrats who voted to approve Marty Makary as FDA commissioner. You know, we learned this week that Makary signed off on pushing out a top vaccine advisor, Peter Marks, and also those widespread layoffs at the health departments, including at FDA. I'm curious, you know, can you tell me a little bit about the calculation you made there in voting for Makary?
Yeah. So Dr. Makary has a very strong record of fighting the opioid epidemic and being realistic about the FDA's role in fueling the opioid epidemic. That is an epidemic that has devastated my state, and somebody at the FDA needs to hold the FDA's feet to the fire on the opioid epidemic, among other things. But let me talk a little bit about what is happening at HHS with regard to vaccines. Over the course of human history, we have seen charlatans, people we used to refer to as snake oil salesmen, exploit people's fears and their hopes and their desperation when it comes to illness of themselves or a loved one. And the way we have combated those charlatans has been with science. Science is the solution here. We now have a Secretary of Health and Human Services who is anti-science and dragging us backwards. Not only have they forced Peter Marks out, the guy who was, according to news reports, the person behind Operation Warp Speed, which has saved millions of Americans' lives, and brought in anti-vaccine pseudoscientist is the best way I can describe him, because he's been disciplined for practicing medicine without a license and administering drugs to children with autism that have harmed those children. And those drugs they were like prostate cancer drugs. And that's who he has brought in. So we are being pulled not only away from science, but into an anti-science mode by Secretary Kennedy. It is really disturbing, and it is something I hope to be able to ask him about should he appear before our committee, which he is supposed to do.
So on McCarry's opioids, as a priority, the Trump administration has revoked, billions of dollars in funding for grants linked to addiction and mental health. They're folding SAMHSA, the Mental Health and Substance Abuse Agency, into another agency.
Right.
Do you feel misled at all on that front? Was there something that he said that convinced you to vote for him?
I think Dr. McCarry, in good faith, said he is a scientist who follows science, which right now is really critically important, as I just laid out. And as I said, look, I voted against Joe Biden's nominee for FDA because he had been part of a group at the FDA who, to put it mildly, was misled by the industry and allowed the industry to fuel the opioid crisis and did not insist that the industry follow all the regulations and approvals it needed to do for the prescription of opioids for chronic pain and outpatient care. So I take Dr. McCarry at his word about that. I obviously have a lot of concerns about what's happened in the last week and will continue to push the FDA, for instance, to rehire some of the people. Some of the layoffs make no sense in terms of, again, the investments we've already made in critical drug development.
I have one last question for you. Based on a little back-of-the-envelope math, among Senate Democrats, you're tied with Senator Shaheen in voting most frequently to confirm Trump cabinet nominees. You're also among a handful of Democrats that voted for the continuing resolution. Mm-hmm. There's a debate among Democrats about how to handle the Trump administration, and you're taking a position here. Why is that?
I voted to keep the government open because empowering President Trump to have unilateral power was not something I thought was right. And I think a lot of people hadn't realized that with a government shutdown, President Trump and Elon Musk would have even more power. And the thing about government shutdowns historically in this town is that both parties have an incentive to reopen the government. I do not believe Donald Trump and Elon Musk share that incentive. And so I thought it was far more dangerous to allow the government to be shut down under this administration. And I think because I see clearly how Donald Trump and Elon Musk think of themselves, which is as rulers, not as leaders or servants in a democracy. So I think it was critically important to keep the government open, as difficult and bad as the terms of the continuing resolution were. And I think we're seeing that play out right now, which is people in my state, as decimating as some of these cuts are, there still is some functioning government going on. Now, that is not, that should not be the bar and the goal. We need, again, Republicans to join us in standing up to this president. And it will just take a handful in each body. And they have to decide where their commitment lies, whether it is to their constituents and the democracy and progress, or whether it is to Donald Trump, who is on a regular basis violating the law and violating the Constitution.
So beyond the CR, why vote for some of these nominees? Why not stand up to the administration? The people in your state are being decimated by some of these decisions.
The people in my state are being decimated by the decisions of this administration. And what this administration has proved time and time again is that it is bound and determined with Musk and Trump to create chaos and confusion and cause great harm and be really cruel in the process. Now, there are some nominees who I think are qualified people who are trying to act in good faith. I think one of the things we have learned over the last couple of months is that some of the people who are qualified and seem to be acting in good faith are either just doing what the administration says or has no voice in the administration, and that is certainly influencing the way I look at future nominees.
Senator, thank you so much for your time. Up next, we have Politico's Lauren Gardner, who is sitting down with FDA Commissioner Scott Gottlieb, Please join me in welcoming them to the stage.
Thank you.
Thank you so much.
Really appreciate it. Thank you.
Good morning, everyone. I'm Lauren Gardner. I'm one of Politico's FDA reporters, and I'm very excited to be sitting here this morning with Dr. Scott Gottlieb, former FDA commissioner during President Trump's first term. And we've got a lot to talk about the president's second term and some of his decisions thus far on health policy and personnel. So let's get right to the big news that broke yesterday. HHS, thousands of workers received reduction in force notices. You posted on X yesterday that 25 years ago, the notion was that Europe was ahead of us on biopharmaceutical innovation and that we lagged and that we made policy decisions that flipped that around. How do you think the cuts that were announced yesterday are going to affect that?
Well, look, I think they're going to be deeply impactful. I think that there was a lot of cuts made to components of the review process that maybe the people who were doing the reductions didn't fully realize what role they played in actual drug review. It seems that anything that had the word policy in it as an office was eliminated. And, you know, perhaps there was a proliferation of the title of policy. People like to hold a policy title in the federal government, but there were a lot of offices within the review divisions, within the Office of Generic Drugs and Office of New Drugs that ostensibly were called policies. So there was a distinct office of policy within each of those groups. But what they did was help adjudicate cross-cutting scientific issues that transcended different drug reviews. So if you had an endpoint that was used in multiple clinical trials and you had to make a determination about the comparability of the results across different drug reviews, or if you had a side effect associated with one drug and you wanted to make a determination whether or not it was a class side effect or specific to a particular molecule, that office made those adjudications, did that evaluation. So without that function, they touched literally every drug review. Now, this is just one example of the offices that were eliminated that I think are going to directly impact drug reviews. And getting back to your original premise, I started there in the early 2000s. It's been a while with Mark McClellan. And we were under a lot of pressure at the time because there was a lot of literature coming out showing that breakthrough therapies were reaching Europeans years before they were available in the United States, particularly more targeted cancer therapies. And so there were decades of efforts by Congress to pass the Cures Act and the FDA Modernization Act and the Food and Drug Administration Amendments Act and the Orphan Drug Act, all this legislation to try to accelerate particularly breakthrough innovation to American consumers more quickly. And it was successful by and large. We really lead the world in approvals of cell and gene therapies and all these novel platforms. And I think that's going to be at risk right now. And, you know, just final point, hearkening back to, you know, my experience in the first administration. Remember, President Trump was the one who championed the Right to Try Act. He believed in the power of pharmaceutical innovation, and particularly these new paradigms to transform people's lives. So I don't know that this is consistent with his ethos about how innovation can impact patients.
Before we drill down more into some of the specifics you brought up, who do you think is making these decisions on these cuts? Is this DOJ? Is this Secretary Kennedy? How much do you think the new commissioner, Marty McCary, was involved?
Yeah, well, what I was told was that I think the directive to make the reductions came from DOJ, and certainly Secretary Kennedy was involved in that decision. I think the actual adjudication of it, from what I understand, was done with a very small group inside FDA. And the center directors weren't consulted. And so the center directors are in a position to know what the components are that would impact review function, what would impact core function. And so to make reductions in the review process without directly engaging them, remember, we had to do RIF planning when I was there. There were various points when there was a directive from OMB that you were going to have to reduce 1,000 people, 2,000 people. So we had those plans. And we worked closely with the center leadership to try to do it, to try to plan in a way that we wouldn't impact sort of core public health functions. And it was hard, but you could do it. You know, every agency, there's ways to eliminate positions. I don't believe that was done in this case. I mean, I think you know the same thing from your reporting. This was a very small group of mostly political leadership inside the Office of the Commissioner. And that's why I think you see some of these things like, policy eliminated everywhere across the agency, but not all of it was really a policy function.
So you were talking about the kind of universe of staffers who orbit, let's say, the reviewers. And, before the cuts were formally announced, the HHS was saying the review processes for drugs and devices, like the reviewers will not be touched. So can you drill down a little bit more specifically for us? What does it mean if a reviewer does not have the pharmacists or the biostatisticians or the other folks around them helping to support the review process? What does it mean if there's an application on their desk for a new cell or gene therapy?
Yeah, so the biostatisticians and the pharmacists would be part of the review process too. But let me give you sort of an example with the generic drugs. When we were trying to create new incentives and new avenues to genericize complex drugs, for example, so we brought the first generic EpiPen to the market. That was a big issue back when I was there, where you had to come up with a way to be able to genericize a drug device delivery system where there was IP, patent protection around the device itself, and there was very specific instructions for use that made it hard to write a generic label to it. So the company had patented the device, but not the drug. So we had to come up with a policy formulation for how reviewers can approve a generic version of that product by basically carving around the intellectual property on the device itself. And what we said was, well, as long as a consumer can go from one device to the other, even if they don't have exactly the same instructions for use, as long as they can pick it up, and you can demonstrate through what's called an actual use study that they can go from one device to the other and not get confused, we can approve the generic version even if it's not exactly the same device. And lo and behold, we were able to get these generics onto the market. That is the kind of policy formulation work that happens within the division, that without that policy formulation work, you can't make those generic approvals. And that's one example. That happens literally every week. For every generic approval that's a complex drug, of which most of the high-value generic opportunities are complex drugs, you need that policy formulation to give the instructions to the reviewers how to do it. And you need to be able to issue what we call good review management practices that basically is a recipe for what reviewers should do, what rules they should follow when they're reviewing applications, particularly in areas of novel technology or breaking new ground like a novel generic approval. That apparatus is what's gone. So that is going to have a very tangible effect on some of the areas of both new technology but also novelty, wherever there's novelty. So things, approving a statin is not going to be difficult for the agency, right? They know how to do that. But trying to genericize a complex formulation where there's no precedent, that's where they're going to have their hands tied now.
What about inspections? That's another major role that the FDA plays, inspecting facilities that make these drug products, both here and abroad.
Well, look, when you talk to the folks around DOJ, I think they were very clear that they didn't want the review and the inspectional functions to be impacted. Now, that's a directive coming from people who are very far removed from the actual review process. I think on the implementation, if the implementation isn't done in a very thoughtful way, where you're actively engaging the professional staff that understand this, you're going to impact inspectional functions, because to send an inspector out into the field, someone's got to book their travel. You've got to get the clearances, so the international office gets the clearances, make sure there's security on site, and if there's not, we provide for it. Someone's got to process their credit cards. People bill their travel on their personal credit cards, and they don't want to go out into the field if they're going to accrue a big credit card bill. All these things need to get thought through. We were active. I know these issues because during the government shutdown, we were actively adjudicating all these issues because my inspectors were there, but all the support staff wasn't there, and I was still trying to get them out into the field to do inspections. So there's a lot of these very detailed issues where there's 2 or 3 or 4 FTEs standing behind a reviewer or an inspector every time they're performing a critical function.
So given all of these trickle-down impacts that you're outlining for us, do you think, was it a mistake for Senate Republicans to confirm Secretary Kennedy, in your view?
Well, look, I certainly expressed my opinion about the Secretary, and it wasn't focused on these kinds of issues. I mean, I think we knew these kinds of issues were going to come up related to an effort to downsize the government, and in the question of how thoughtfully do you do that and how gradually do you do it. My concerns, as you know, primarily turned on his position around vaccines, and my concern, which I think has been borne out, that he would interfere very directly in the vaccine approval process, which I think we're going to unfortunately see. but also in terms of the infrastructure that we rely on in this country to get children vaccinated for things like polio and diphtheria and measles, mumps, and rubella. And I think we're seeing that as well. The one really, look, he canceled the FDA advisory committee that made decisions around the selection of the new strain for the flu vaccine. They've canceled grants on new vaccine production. We've seen him take down front-facing pages of the CDC website that encourage people to get vaccinated. And probably the most tangible step that we've seen in recent weeks was during what is the biggest flu epidemic that we've had in 20 years in the United States. They took down a campaign that was encouraging people to go out and get vaccinated for flu. So that is a very deliberate step in the setting of, a public health crisis with respect to the flu. Now we see offices getting closed that are going to vaccinate people in West Texas for measles. There's probably thousands of cases of measles in West Texas right now. There's vast underreporting when you talk to people on the ground. So, these are all very tangible things because I think his career has been dedicated to these sort of anti-vax efforts. I don't think he's made a mystery about it. I don't think we should be surprised. He's been very clear. You can't fault him for not being very clear about his intentions here. I think the people who thought, well, maybe he won't follow through on it, I think they were the ones who probably, maybe have some buyer's remorse. I don't.
And related to that, how do you, given all of this context that you just talked about, and on top of that, the rifts yesterday, how do you anticipate now Commissioner Marty McCary to work within this ecosystem now of dealing with this, the Secretary's position on things like measles and advocating for different treatments, and now doing this in the context of fewer people in government working on some of these issues who have been there for a long time?
I think Marty's got there's going to be some very early tests of whether or not Marty is going to, and Marty's a friend. I think he's very good. I was glad to see the senator make some complimentary remarks about him and also to support him in the Senate. But I do think there's going to be some very early tests, perhaps within days. We have PDUFA dates. That's going to give us an indication of how much he is going to establish independence about the decision-making there, not just on the policy, but on product-specific things related to vaccines, or how much he's going to be pressured by the Secretary to do certain things that are clear evidence of sort of political decision-making in the scientific and review process. We all got it, although I was fortunate. I mean, Alex Azar, in many ways, was exceptional. He understood that it was important to maintain the independence of FDA, and he guarded that. But, I've been in and around FDA for 25 years. There's always secretaries who think that they can get involved in certain decisions, and you have to educate them about the importance of maintaining that firewall and the independence, because it serves them well at other points. I don't see the respect for that right now, and I think we're going to see some really visible tests of that very soon.
Is there a particular bright line?
I think we should just watch the news flow. I'm sure if there's a bright line, I'm going to read about it in Politico.
That's true. So I do have to bring up, you were name-checked a little bit earlier in the program by Kennedy advisor Callie Means. As to sum up, you're a part of a medical establishment. You're on the board of a pharmaceutical company, and you're raising alarms about things like measles, and the suggestion is that this is all done while ignoring chronic diseases that afflict many Americans. Can you address the general belief that there's some kind of tension between dealing with infectious disease issues and chronic disease issues?
Look, I can address it very simply that a lot of chronic diseases are a manifestation of infectious disease. I mean, we look at all the emerging data. I had a B-cell lymphoma that when they sequenced it, it had Epstein-Barr virus in it. And if I had never gotten Epstein-Barr virus, I would never have gotten cancer. And now there's links between Epstein-Barr virus and multiple sclerosis, where I think the data is very convincing. So I think a lot of chronic debilitating disease, autoimmune disease, have infectious disease origins. Look, I think that the Secretary's tapped into a lot of concern among consumers that general health isn't good in this country, that diet has a very important nexus to our health, and that healthful opportunities, especially eating opportunities, aren't available to every consumer. Not everyone can go shop at Whole Foods. And we have competed in this country, food companies compete on portion size and taste and packaging and not the healthfulness of their foods, largely because they can't make qualified health claims on food labels. I think there's a lot we can do to improve that. I think it requires a lot of complex policymaking, which I haven't really seen evidence of yet. But I do worry that a lot of the anti-vax sentiment, or a lot of this kind of movement is really an anti-vax movement, and some of the MAHA stuff, for some people, is just the wrapping around what is really a much more deliberate anti-vax campaign. And the evidence of that to me is when you have people like the person who name-checked me this morning, who goes out and talks about some of these things around food and that are more kind of like MAHA related, however you define that, he gets attacked by the anti-vaxxers that he's not being anti-vax enough. So I think, the fellow travelers are taking heat from the anti-vaxxers because they're adhering to the MAHA part of the agenda, not the anti-vax part of the agenda. So that's very revealing to me. I think this is a much broader anti-vax movement with a lot of other things wrapped around it. And unfortunately, that may leave some consumers who believe in the other components of this agenda disappointed.
I'm running out of time, so one final...
You're out of time.
Don't tell them. Don't tell them. It's ratting me out here. One quick final question. You commented on Dr. Peter Marks' resignation at the end of last week, but I want to broaden it out a little bit since we've covered that pretty closely. What is your response to the critics who say that the secretary should have the bandwidth to make staffing changes within the department and further down into the agencies that he sees fit to carry out his agenda? What is this?
Yeah, look, the secretary does have broad authority. There's no question about that. I think a lot of secretaries for 20, 30 years have respected maintaining a degree of independence of the agency because it served them well. Even if there were things they wanted to do, they knew crossing that line would come back to haunt them in certain ways, because when they wanted to separate themselves from an FDA decision, then they wouldn't be able to. Now they own the whole thing. Peter was an exceptional leader. You think back to the early 2000s when I got there, we didn't even have a cell and gene therapy group. In a decade, Peter really presided over the creation of that modern industry. There's 2,000 cell and gene therapies in development right now, 35 in phase 3 trials, 300 in phase 1 clinical trials. They're transforming patients' lives. I will tell you personally, we approved the first gene therapy when I was there. I remember briefing the president on it and how enthused he was about the drug Kymriah, the CAR-T drug that transformed the lives of patients with ALL. That approval would not have happened on time without Peter's involvement. That was a very sort of bespoke regulatory process in many ways, where a lot of the senior leaders were involved in those reviews because it was such novel technology. And I do worry, more than anything else, I worry about the impacts on that group in particular, because it's not just Peter. They took out the senior leadership of that entire group and some very good people. Meyer, who ran the policy shop, again, not a policy shop, it did review functions. The head, Janekis, who was head of regulatory operations in that group and kept all the trains running on time. I think that segment, we really need to go back and re-adjudicate what they did with respect to those reductions, because that's going to have a very tangible impact on patients whose lives can literally be transformed with a gene therapy that could, end a debilitating inherited disease like sickle cell disease.
All right, and we'll leave it there. Thank you so much, Dr. Gottlieb, for joining us.
Please welcome Politico's Vice President Client Partnerships, Heidi Sommer, and Hackensack Meridian Health CEO, Robert Garrett.
All right, good afternoon, everyone. My name is Heidi Sommer. I'm the Vice President of the Media Business at Politico, and thank you all so much for being here for our annual Healthcare Summit. It's my very great pleasure to be joined today for the fourth year running by Bob Garrett, CEO of Hackensack Meridian Health, an invaluable partner of today's summit and over the past several years. Bob, thanks so much for being here today.
Well, Heidi, it's good to see you again. Thanks for having me back, and happy fourth year anniversary here.
Same to you, same to you. So by way of background on Bob's experience, he's been recognized as one of the 100 most influential people in healthcare in the U.S. by Modern Healthcare. He's also a global leader and chaired the World Economic Forum's Health and Healthcare Governors Community. So Bob, this is becoming an annual tradition. And what we're talking about today throughout this summit is a really critical challenge, specifically around the healthcare workforce shortage. Hackensack Meridian Health is doing tremendous work on innovative recruitment, academic partnerships, upskilling programs, technology-driven solutions to build a more diverse workforce. So I'm really excited today to hear your perspective on this topic, and I want to start with a little bit of context for our audience, and ultimately to get your perspective on why is there a shortage in the healthcare workforce? Is this a new challenge? Has it been a long-lasting issue in the industry? What's your take and why Hackensack is so focused on this issue?
Well, thank you for that, Heidi. And, first let me say, I've been in the field for quite some time now, and the workforce shortages have persisted throughout my career to different degrees, but they have been there. And I really don't think, number one, that they're going away. Number two, I think they've actually gotten worse for a variety of reasons. You think about it, it's a tough field to go into. The population continues to age, so there's more chronic disease that we need to treat, and that's putting pressure on the healthcare system, requiring more physicians, nurses, pharmacists, therapists, x-ray technicians, et cetera. So there's a lot of pressure there. There's also a lot of burnout that's happened, particularly since COVID. And we've seen that, and we've studied this a little bit. And the number one thing that comes up when you ask doctors or nurses why they're retiring or why they're leaving the field, it is burnout caused by the fact that there's so many other burdens put on them these days. They're not spending enough direct patient care time. They have to be burdened with administrative tasks or charting tasks and that type of thing. But, there definitely the numbers are there. I mean, I think we heard it before. There's up to 130,000 physicians that we're going to be short over the next 10 years on the nursing side. And it's kind of crazy to think, but since COVID, 100,000 nurses have left the field. They've either retired early or they're in other fields. But what's even more disturbing than that statistic is in recent surveys, 1 out of 4 nurses, meaning 1 million additional nurses, are seriously thinking about leaving the profession in the next 5 years. So when I say I don't think it's going to get better, I think these statistics kind of bear that out.
Those are really staggering numbers. And you talked a little bit about the causes. What are some of the tangible impacts on healthcare systems coming from those numbers? How does it affect the communities? I know Hackensack's always been very patient-focused. How is this impacting the patients on the other side?
It's a significant impact. We are a people-oriented industry, and if there are shortages of key personnel, key people, that's going to impact the communities. It's going to impact our healthcare system. A couple examples of that, I think. 1 out of 3 Americans don't have a primary care physician. We have a huge shortage of primary care doctors that are out there. That's creating access issues for people. They're not able to get their annual checkups. They are not able to get their screenings, and we're not doing enough on the prevention side, where some of other Western countries have done a much better job with that. But because we have this primary care shortage, it's impacting our community. So what happens is if somebody really does get sick, they end up in a hospital emergency department. That's not the best place for somebody to receive primary care, number one. And number two, it drives up the cost of health care as well. So I think that's an example on the physician side. Now, on the nursing side, particularly during COVID and after COVID, because of the significant shortage of nurses, I mentioned 100,000 left the profession. Many hospitals and health systems had a staff with what we called agency contractual nurses, and that drives up the cost of health care as well. So it has a profound impact because you're paying these agencies significant dollars. And we were thankful that we got the support from some of the agency nurses, but quite frankly, our own team members are probably better equipped to deal with patient care. They know our health system, they know our hospitals, they know their physician colleagues, they know our processes and systems. So, it's a disruptor, if you will, to the health system, but also a profound impact on the communities that we serve as well.
And how would you say, for Hackensack directly, how have you all been experiencing this, and how have you been thinking about acquiring, retaining talent in this shortage?
Yeah, so I think we kind of jumped out ahead of it to some extent, but you know, in some respects, you have to play catch up because obviously no one anticipated the pandemic and the burnout that occurred. But one of the strategies that we've used is to kind of grow our own, if you will. So we established a new medical school several years ago, the Hackensack Meridian School of Medicine. Since that school's been open, we have graduated 400 new doctors. And I'm happy to say one of the objectives of the school was to attract and retain talent in the state of New Jersey. And about 50% of all of those graduates now are staying in New Jersey and practicing medicine. But even more importantly, they're practicing medicine in areas where we have severe shortages, like primary care, like psychiatry, general surgery, obstetrics and gynecology. So that's really been an effective strategy. We also have opened 3 nursing schools within our health system, and that's really important too because there's about 1,000 nurses that go to those schools, and I think we graduate approximately 300 each year. So that's really a source of recruitment for Hackensack Meridian. But you know what? That's not good enough. We also have partnerships with, I think it's 6 or 7 other nursing schools as an example. And that's really important, really, to have those kinds of active partnerships for recruitment, for retention. And actually, our team, our educators, actually serve as adjunct professors at some of those schools to really assist those schools in the educational process. So that's a little bit of what we're doing on that side. But the other piece is we want to be as innovative as possible. And we just recently announced a global partnership with Apollo Health, which is the largest private healthcare organization in India. And India happens to have a well-trained workforce in healthcare, particularly in nursing. They also have an excess supply of nurses. So we're hoping through this partnership that we're going to be able to attract some of those nurses to actually practice in New Jersey. And certainly, through technologies, maybe even assist some of our nurses through a virtual nursing program. So sometimes you got to think a little bit out of the box. I mean, I wouldn't have thought really a few years ago about a global partnership like that, but it makes sense. It made sense for them because these nurses really do want to work in the U.S. and it makes sense for us. And then the last piece I would say is, establishing a healthy, aligned culture is really, really important in terms of recruitment and retention. And you want to reduce turnover. Our turnover at Hackensack Meridian Health for nurses is half the national average. I think it's 5% vacancy factor we have now. It's a 10 or 11% across the country. So, I have actually some breaking news to share on the cultural perspective. It was just announced this morning that we made the Fortune magazine 100 best companies to work for. And I think beyond the recognition, what that illustrates to me is that we have a healthy culture. People want to work at Hackensack Meridian, and they know they can advance in their individual professions. So it's kind of our recruitment and retention tools have been really multifaceted.
That's tremendous, and congratulations on the Fortune placement.
Thank you.
That's no small feat, and certainly a testament to the work that you're doing to retain talent, recruit talent, like we're talking about. I'm curious because you talked a bit about the medical school piece of this. What is your take on the role that colleges and universities play in this? And ultimately, do you think that they have the right infrastructure to effectively educate the next generation of healthcare professionals?
There's no question that colleges and universities have to play a major role, but they have also been challenged. There's financial challenges that go on at the colleges and universities. There's a shortage sometimes of educators that will help educate the healthcare workforce. Sometimes they're constrained by facility limitations. So when I talk about a partnership, I really want to jump in there and help them wherever I can. So as I mentioned before, we have educators that are actually serving as professors at some of these schools that we have partnerships with. We also have placement coordinators that actually help for a smooth placement process for some of the nurses that are coming through the program. So I think certainly the universities and colleges play a very, very critical role, but I think health systems have a responsibility too to partner wherever we can help each other, I think, through these innovative partnerships.
And in terms of, you touched on this a bit earlier, but as we think about technology and the continuing role that evolution is playing in healthcare, what are some of the innovations that you think could help with training, upskilling, and sort of making these systems more efficient?
Technology is absolutely going to play, has been playing, and will continue to play a major role in workforce development. So just let's take a basic technology like telehealth. It really has extended the workforce. So particularly in the mental health space, I think it's about a quarter of all of our mental health visits to professionals are done through telehealth. It's an important tool that's out there. We just recently entered into a partnership with a company called K-Health, and we rolled out a program called HMH 24/7, and it established a network of virtual primary care providers so that people 24 hours, 7 days a week can access a primary care provider through this telehealth technology. We also, technology is also helping us establish programs like a hospital at home program. So remote monitoring, 24/7 remote monitoring really helps us monitor patients so that nurses and support personnel and even doctors don't have to necessarily visit the home around the clock. Patients can be seen at home as opposed to in the hospital, which will free up beds for other acute care patients. So that technology is really important as well. And then, I know some of the other speakers mentioned AI this morning, and we have some really exciting AI algorithms that are helping, I think, on the burnout issue. As I mentioned, physicians and nurses, one of the biggest indicators on the workforce has been burnout. And we have some algorithms that are really helping in real time. We have one that's helping physicians. It's actually reducing the amount of time that they are summarizing their charts each and every day by up to 2 hours through a AI summarization algorithm. And that frees up doctors to spend more time with the patients, but also spend more time with their families, which reduces burnout as well. So I think technology is going to play a huge role in extending the workforce and trying to fill in some of the gaps that exist today.
Yep, some tremendous opportunities, sounds like still to come there.
Yes.
Last question for you, Bob. We're here in D.C. We've got a new administration, a new Congress. And I always like to end these conversations sort of zeroing in on what do you want this audience, what do you want the policymaker community in Washington to know as it relates to what healthcare systems ultimately need to tackle this workforce shortage?
Yeah. By the way, I hadn't noticed there was a new administration, new Congress. No, just kidding. What I would urge is, and I've mentioned some of these initiatives already, but as an example, telehealth. Telehealth has been strung out in terms of funding on these continuing resolution bills. It needs to be made permanent. We saw the difference it made during COVID. We've seen the difference it's made since COVID. It's part of every healthcare delivery system today. The funding needs to be made permanent, and that's where the Congress can really be very, very helpful. One of the impediments in really training the next generation of physicians is not just opening up a new medical school like we did, and others have done the same thing, but it's also making sure there's enough residency spots so that the training can happen at hospitals. And the Congress really hasn't substantially increased the training reimbursement that hospitals get since the 1990s. So that's really important because that's really holding up the pipeline to get some young talent to practice medicine where we have these physician shortages. So that's another area as well. And then, this may be specific to Hackensack Meridian Health, but listen, I think we need to actually ease some of the visa restrictions that are out there so that we can get talent like from places like India where the nurses are so well trained, and there's other countries too that have a supply of healthcare professionals that want to practice here. So we need to ease those visa requirements. I even actually heard Elon Musk saying that there's a shortage of nurses, and we need to think maybe a little bit more broadly about recruiting some new nurses to this country.
Well, with that, Bob, we are out of time, but thank you so much for this conversation today, and to Hackensack Meridian Health for their support of the summit. This has been a tremendous opportunity to partner with you all the last several years, so thank you again, and I'm excited to introduce our next conversation. Hope everyone has a wonderful afternoon.
so much.
Oh, I see some of you getting up. You should stay. You should stay. We still have more. We're just doing a little set change here, and coming up is our conversation, a panel on AI integration in healthcare, and we still have Dr. Vanessa Carey and Dr. Atul Gawande. Sorry, guys, I'm getting tired. And coming up after this, and one more shout out and thank you to all of our sponsors today: PCMA, the Joint Commission, Walgreens, Hackensack, and Advil. We wanted to thank you all again. Thank you all for being here, and my vamping worked. There we go. We'll see you in a sec.
No promises.
All right. Good afternoon, everyone. Thank you so much for joining us. Today I'm sitting down with Democrat Congressman Ami Bera of California, who serves on the House AI Task Force, along with Kev Coleman, a research fellow with Paragon Health Institute, and then Brian Anderson, the co-founder and CEO of the Coalition for Health AI. And we are going to discuss artificial intelligence and the healthcare space and all the work that needs to be done in order to make this a safe endeavor. So the future is now. I'm sure everybody in the audience already knows. AI is upon us. Health systems are using it. There are very few guardrails, and there is not even really industry consensus on what those guardrails should be. Congressman Bera, you are a member of the House AI Task Force, and your task force issued a report that sort of looked broadly at the industry. It wasn't focused on healthcare, though you did look at sort of the implications for healthcare. And the report highlights a lot of ways in which AI could be beneficial, but also the risks. The most bipartisan takeaway seemed to be that this is something that we need to be investing in, right? And that includes, in fact, I have a quote here. I'll just quote from it. Sustained strategic investments in research and development will be critical to maintaining U.S. leadership in AI from the NIH and others. And so given the priorities on cutting the federal budget, I'm curious, where will this investment come from?
So first off, thank you for having me here. I think Speaker Johnson and Leader Jeffries were prescient in creating the task force, equal numbers of Democrats and Republicans, and it was pretty nonpartisan, which is hard to say in D.C. these days. Congress can appropriate those dollars, right? I mean, we have to, because we know AI is coming at us. And so we made recommendations. We created a framework. We hope that we'll create a select subcommittee, because what we worry about most is 50 states doing 50 different pieces of regulation. That would be a disaster. I'm a Californian. We were able to stop some of the California, and it was thoughtful legislation, but again, we think Congress should put in those guardrails to provide safeguards, but not to stifle innovation. And we think there's an urgency there.
To do it. And so you think that even though there is sort of this pressure to cut costs, and even there has been cuts to research investment, that you can still make those dollars?
Absolutely. Yeah. I mean, the dollars are going to come out of the private sector as well, but it's our job as Congress, right, to put up those guardrails. We were slow to the game in social media, and it's really hard to put up those guardrails today. We can't make that same mistake, and we see how quickly AI is evolving.
So another big question in industry and that government is grappling with is how do we ensure that AI in healthcare can be safe? And the FDA, the Food and Drug Administration, has provided some guidance on this front, but AI is really different than sort of what they have regulated in the past. It changes, it can degrade, it is adaptive. And there's a lot of concern about how to monitor and ensure that this technology is safe after it has been authorized. Former FDA Commissioner Robert Califf has talked about this. He said that the agency needed more staff to do this, and that Congress should either clarify or potentially expand the FDA's authorities in order to do more monitoring once that technology has been released. And so I'm curious, given the report, which did mention this as well, that this is something that Congress should look into, what is the consensus so far among your colleagues?
Yeah, so talking to industry and the way we approached on the healthcare side is we put out a request for information, how folks were thinking about it. We got a lot of really interesting insight. I think we did reach a conclusion that the FDA had the authorities that they needed on the front end, but as you pointed out, AI is different, right? So an algorithm that you might approve as safe and effective today, in generative AI, it's learning and so forth, and a year from now, that may be a very different algorithm, and the FDA is probably not equipped to say, okay, let's go back a year from now. So we've got to figure that, I don't think we'll let industry self-certify, but what's that middle ground where the FDA can do the initial approvals, but then again, as these algorithms change over time, they'll be different a year from now, 2 years from now. I don't think we have an answer to that question just yet.
Yes, though luckily on this panel, we have two guys here who have some ideas about this. So Brian, would you talk a little bit about how the Coalition for Health AI wants to approach this problem of post-market surveillance?
So first, it's a huge problem, and Commissioner Califf, Commissioner Gottlieb, and others that have spoken about this blind spot with the FDA are exactly right on. In CHI, what we're trying to do is bring together a broad group of health systems that are interested in essentially standing up this kind of post-deployment monitoring capability. Because right now we don't have that in AI, right? You look across the different regulatory areas that the FDA approves, be it drugs, devices, vaccines, other areas, there are post-market deployment surveillance networks. We don't have that in AI. So in CHI, what we're doing, again, industry-led effort, where you have vendors working alongside health systems, wanting to understand in the local environments, in the health systems, where these models are deployed, how they're actually performing. We don't have that kind of hard data yet. And so in CHI, we announced this nationwide registry several months ago. The point, or one of the main efforts is going to be to create a space transparently available to the public where health systems can share how these models are actually performing in their local environments. And we can learn something from that, right? If you have a sepsis model, the same kind of sepsis model that's deployed across 10 or 15 health systems, understanding how that model performs in each of those local environments and where there might be differences in that performance, we'll learn a lot from that. And so that's part of the process that we're trying to stand up, is that kind of transparency and that kind of shared understanding of how these models perform.
Okay, great. Now, Kev, you also put out a report on this idea, and in particular, you think that the FDA plays a pretty strong role in this, and so I would love for you to talk a bit about that.
Certainly. The FDA has a long precedent of evaluating and reviewing software as a medical device, and this applies equally to AI whenever it's being used in the treatment, prevention of disease, et cetera. However, these models of review in the FDA originated within the world of mechanical devices and deterministic software. And what we now have with AI is certain forms of technology that may exhibit at times unpredictability. Now, unpredictability is not necessarily a bad thing. It actually could be quite beneficial. When we talk about unpredictability, I don't necessarily know in a test bed a future outcome. Well, that sounds, threatening with something like generative AI, doing some type of verbal output to you. However, what about a probabilistic adaptive system that's going to improve its diagnostic accuracy over time? And this is where I think there's a profound opportunity for a public-private partnership, one that leverages the collective self-interests of developers, of health systems, of insurance carriers, and even some of the major infrastructure vendors within the EHR space. Currently, I've drafted or co-authored a paper with Dr. Michael Pensino over at Duke University, the head of Health AI over there, and we're going to be dealing with a targeted post-market surveillance model that doesn't just randomly increase the costs of AI, but tries to introduce a non-disruptive model that can make sure that AI flourishes as a national concern while at the same time addressing some of the legitimate safety concerns that the technology evidences.
But do you think specifically that the FDA does need some expansion of its current authorities to play its role?
You know, given what I've seen of FDA authority, they seem to have what they need. I have heard that statement claiming that they don't have authority. That seems to be more of an issue of, you know, agency-specific regulation than necessarily new legislation. Now, if someone could, show me a deficit within a specific a law, I'm happy to review that. But at least at this point, I haven't seen those deficits that's being spoken of.
Did you want to add to this, please?
Yeah, I mean, I'd agree with that. I think they've got the authorities. How they interpret and utilize those authorities, they may have to modernize. But I think our sense is they've got the authorities to do what they already do fairly well to this new technology.
I absolutely agree.
So which then means we're sort of talking about clarifying what they do in order to sort of meet the moment.
Yeah, I think adaptation, and I'd love to hear both the representatives' opinions as well as Brian's. But an FDA as an oversight agency is constantly having to evolve to the material realities of the marketplace. This is just one more instance of this. That's a complicated instance. You have to get into things like, what's a deterministic algorithm versus a non-deterministic one.
Mm-hmm.
How do you deal with training data characterization and the implications for outcome uncertainty? Okay, that's complicated, but that's all seems to be within their wheelhouse.
Well, and part of the reason I even bring up the FDA at all, I mean, it is their job historically to regulate these technologies within medicine, but one of the reasons that people talk about whether or not the FDA has enough authority is because I think there is some concern about an industry-led model and creating too much room for regulatory capture, which we're going to come back to.
Right.
But first, I wanted to ask you, so what is the potential for Congress to pass a bill that would sort of clarify FDA's role in post-market surveillance?
Yeah, so again, I don't know if it's a new piece of legislation per se or just working with the administration in that capacity. Congress isn't a highly functional body right now, so I'm not sure that legislation's going to have legs. But I think, again, we could work with the administration in this particular context to provide that guidance, provide those definitions. But there's still real big questions left out there, right? Because, again, I think the FDA has everything it needs to do initial approvals, but what's that ongoing approval look like?
And Representative, would you also feel that there's a great need of clarification, at least at the public level, regarding healthcare domains? We talk about healthcare regulation, but they don't necessarily understand that within healthcare, you actually have a bunch of subsectors that need to be treated separately. AI within a front office appointment setting context is much different than within a clinical setting, which is much different than within claims adjudication versus an insurance company dealing with prior authorization. And I get very worried when people want to lump all those things together because it can lead to a profound amount of inefficiencies and also adding a lot of incremental expense within an already profoundly expensive American health system. I will just say for myself, one of my greatest concerns as a researcher is the amount of money that we expend as a nation on health care. We're now up to, 17.6% of the gross domestic product, up from 17.3 the last reporting period. That 3.3 to 0.6 is hundreds of billions of dollars. We need to be able to find ways to leverage AI to maintain and improve quality standards, but most importantly, reduce the cost of healthcare delivery. You cannot reduce insurance premiums unless you actually reduce healthcare delivery costs.
100%. I mean, I think that is something Congress can do. Can we put the incentives in the right place? Can we incentivize innovation? One thing we worry about, and Robert's group is doing great work in terms of collecting the information. And we're in a benevolent phase where big health systems, folks that are already doing stuff, are sharing that information. Mm-hmm. But at some point, let's say, a big health system that comes up with an algorithm that reduces hospital length of stay by 2 days, they're going to realize they've got a competitive advantage in the marketplace. And I worry about the day where they're not sharing their findings and algorithms as freely. it's not happening right now. Again, there's a benevolence and a sharing, and I worry about that.
I'm so glad that you are all talking about cost. So in terms of ensuring that AI is safe, which is sort of the bigger, broader point here, federal government, not a lot of rules around AI. FDA has its remit, has issued some guidance, is working with players, but there's stuff that's not under its remit. You have erected your organization to be a part of this, but also there are several other organizations that are putting out standards now that are erecting their own certifications. Those certifications cost money. There is concern that whether it's health systems or AI product makers are going to have to pay to get certified by CHI, but then they're also going to have to pay to go through the FDA process. And who ultimately pays that price? Where does that money go, right? So that, there's a potential here to inflate healthcare costs. So how do we handle that?
Would you like to speak first?
Yeah, I'm happy to give some thoughts onto this. So, this is something we were actually speaking with a few of the senators yesterday up on Capitol Hill about. I think one of the greatest hopes about AI is driving down costs, as you're describing, Ruth. And, I'll readily admit that probably the biggest driver of cost in healthcare is physicians. I'm one of them, I can say that. We're the biggest, most expensive cost point of labor. Part of the hope with AI, and particularly in the agentic AI future, is the ability to drive down costs by taking on some of that work that physicians spend a lot of their time doing, adjusting medication prescription, looking at the blood sugar levels for a diabetic patient or the blood pressure levels for a hypertensive patient. When you have AI tools that are created safely and effectively, that have the right kind of guardrails around them, there's real opportunity if we have a focused effort and looking at things like value-based care areas, be it with Medicare Advantage or Medicaid or within CMMI, to demonstrate how these tools can drive down cost and not just create another procedure code to bill for in a fee-for-service world. I think that those are the areas to focus on being able to realize that potential benefit that we all want with AI tools.
And can we get the money to do those pilots, I think is a question.
Yeah, I think we can, and I think a lot of that's already happening. I think about the amount of healthcare data that my Apple Watch is collecting. Mm-hmm. How do we use AI to sort through that data to make me, as a physician, a better physician, but also to reduce the cost of care? I mean, it's all there, so we can do this.
Can I just share? I think one of the things additionally is this concept of AI governance. Mm-hmm. Health systems are just struggling with this. So we have over 200 plus health systems in CHI, and nearly every single one that we talk to describes almost an existential concern where we've jumped into this AI game, we've procured these models, and now we realize, just as you're describing, they drift, they adapt, they're dynamic. How do we monitor? How do we manage them? So being able to bring together the health systems of America to identify what are the scalable ways towards AI governance and monitoring, and partner with them to help them deploy that in a financially sustainable way, that's one of the key areas that we're focusing on, Chai. If we don't get that right, there's going to be a lot of health systems that simply can't get into the AI game, and that's what we don't want.
I'm glad you brought up AI governance. So one thing that CHI has done is to create the registry. You've done that in partnership with a company called Avanade. For those who are not familiar with Avanade, it's a spin-out of Microsoft. And so Microsoft is going to be essentially a big player here. I do wonder, and I'm not the only one, representatives within our Congress, Representative Olber-Nolte and several others, have raised concerns about sort of some of CHI's work, just insofar as it does create that opportunity for a big company like Microsoft to capture the market. Congressman Bera, how are you and your colleagues thinking about that issue?
I mean, so again, first, hopefully we reinstitute the select subcommittee, because the more questions we ask, the more questions that come up. And I do think this has to be a public-private partnership, because we're actually working with industry to get this right. And I don't have the answer exactly what that would look like, because AI is going to be a powerful tool to both improve outcomes, lower costs, reduce the administrative burden on physicians, make us better clinicians, and enhance our lives. But if those guardrails aren't up, It could also be used to, to drive profit, to reduce care, we've seen instances where health plans are using it on the prior authorization process in a negative way to deny care. So I think that is why we feel like we've got to get guardrails up, not to stifle innovation, but also to prevent the bad things from happening.
Can
yes,
I respond
please,
to that?
by all means.
So, it's a fair concern. Anytime you have a not-for-profit that's stood up and is trying to be as inclusive as we can be, that you don't want any one organization to have undue influence. Microsoft is a big organization, right? And so in CHAI, we've tried to have a big tent approach. So all of the big tech companies are part of CHAI. But also part of CHAI, those 3,000 organizations, over 25% of our members are startups with less than 50 employees. And we have a set of governance structures in place that are attempting to ensure that there is no outsized influence by any one member. And so a lot of the work we do, building these industry consensus guidelines and best practice frameworks, is driven by the startups that we have. It's not driven by organizations like Microsoft or Google or Amazon. We really make an intentional effort to try to include the investor community, venture capitalists, private equity firms, as well as all the startups that they represent. And so, I think there's a lot of misunderstanding that when you have big tech organizations with really recognizable names, it's like, oh, somehow, CHAI is a cabal of these kinds of organizations. It's absolutely not. The most active members in our community by far are the startups and the health systems. You have startups that want to build trust with their customers, and you have health systems that want to use the most innovative technologies, be it ambient listening technologies from any of the kinds of startups that are out there. And in CHAI, we are building those frameworks that enable that kind of trust to exist and to flourish, along with a set of guidelines for safety and efficacy.
Yes, I will push back on that only slightly to say the platform that you're partnering with, Safe AI Governance, they also have great ambitions to not only be a registry, right, which is what they're doing now, but they also want to do that post-market surveillance. And there are a lot of incentives for health systems to all get on the same platform. So that's why I'm throwing that out as a consideration. Kev, jump in, please.
Oh, certainly. The issue you're bringing up around AI governance is enormously important, and I would never want to dismiss the concerns about regulatory capture, et cetera. I think the larger issue, taking a step back as a former startup executive, having worked within the Silicon Valley model, et cetera, is a point that Brian brought up earlier, which is financial sustainability. AI systems ultimately have to be purchased by healthcare systems, and if you have any type of certification process that is largely duplicative of the FDA and also requiring a highly consultative model of like informatics specialists, I don't think that's going to survive. I will just tell you that's not a model that I think is sustainable. I think this idea of being able to, disseminate standards and facilitate and empower is going to have the day. And I think what you're going to see is a lot of localization around health systems that have a shared AI implementation, being able to share metadata as opposed to private health information to be able to deal with some of this post-market surveillance issues. Though one of my great hopes is that aside from AI governance, aside from all this, is that we actually take a step back and think about the full potential of AI within healthcare. And I would love to see a moonshot initiative where we actually try and take our, tackle our healthcare costs and say, okay, look at the very expensive labor that we've talked about and find ways where we can safely, reduce labor costs through the use of incredibly powerful artificial intelligence. That's exciting, and that's something that will just benefit people on both sides of the aisle. Everyone is being crushed by healthcare costs.
Well, I am at time. Thank you all so much for your time and expertise. We hope to continue this conversation as more changes arise and the technology rapidly develops in the coming years. Next up, join Politico's Sophie Gardner for a conversation on the future of public health and preparedness with Dr. Vanessa Carey of the World Health Organization. Thank you.
Thank you.
Good afternoon, everyone. I'm Sophie Gardner, and I'm sitting down with Dr. Vanessa Carey, the Director General Special Envoy for Climate Change and Health at the World Health Organization. Dr. Carey also serves as the CEO of Seed Global Health, a nonprofit that focuses on strengthening health systems and long-term investments in training the health workforce, and sits as Director of Global Health and Climate Health Policy at the Harvard T.H. Chan School of Public Health. Welcome, Dr. Carey, and thank you for being here.
Thank you.
So,
Great to be here.
I wanted to start by asking, the Trump administration in the past few months has cut global health funding across a handful of areas, the dismantling of USAID, halting funding to the WHO, and freezing foreign aid. What has been the immediate impact of those funding cuts, and what do you expect the long-term impact to be?
Well, the immediate impact has been, without question, a decimation of years of progress. We have been a leader in global health in a way that has actually been a very powerful agent of soft power for this country, and to really help strengthen and make progress on a lot of health goals that have stabilized countries, led to economic growth, and put us on a path actually to sustainable development. All of that has been shuttered. And just to give a sense, there are the clinics in the countries where Seed Global Health works. Many of the clinics have just been shuttered and closed. And so people are going to get their medications, going to get services, and they can't get services. The reports have been that some of the funding has come back online, but it hasn't actually. And so there's a continued disruption of ongoing services that have happened. In Uganda, a country of 50 million people, which is a major hub of economic sort of engine for Eastern Africa and the continent, is facing an Ebola outbreak right now. Ebola is incredibly deadly in Uganda, and without U.S. funding and support, there has been a inability to really respond in the full way. And SEED has been one of the few partners that has been able to respond. And the problem with this is that, for example, the Uganda government hasn't been able to put forth the kind of response it wants. So you can't track people who have traveled and maybe been found to be infected with the disease. The airport has had no contact tracing at all. And so you have the world, therefore, at risk in some ways from it. So what you're ultimately seeing is that millions of people's lives are at risk. But beyond lives, there's a destabilization of economies. There's going to be a failure of progress and development. I am all for, and I think most of us in global health would argue there needs to be a really good and solid discussion about moving towards sustainability. Many countries already have had plans for moving towards domestic financing and away from global aid, but there needs to be time and the ability to execute those plans in action. Decimation of funding doesn't allow for that to happen. So we are effectively blowing up a system that actually was well poised to make some very meaningful progress and a movement away from U.S. foreign aid in the long term.
Yeah, so you mentioned the Ebola response. I'm curious, are there any other health threats or outbreak responses that you're especially worried about?
Well, I think that Ebola without question is a concern, but you have a number of outbreaks that can happen around the world that we're going to continue to see. So in the wake of extreme weather events, we're seeing the largest number of cholera outbreaks around the globe of late. If we destabilize vaccination, you're going to see a rise of polio again. You're going to see a rise of pneumonias. You're going to see a rise of diphtheria, many diseases, and influenzas and others. Many diseases that we have made huge progress on that are completely destabilizing to communities and economies, and that vaccines are really important in first line of defense that we know need to be invested in. So I'm worried about those outbreaks as well. But I'm a physician. I am a believer, actually, that we are seeing an ongoing outbreak of HIV in this world that, frankly, we were about to be able to eradicate and finally see the end of this massive pandemic that's been decades of life, and we are undoing that progress. So we're going to see a 400% rise in HIV now because of the ending of USAID funding or the ending of foreign aid from the U.S. We are going to see hundreds of thousands of children get polio now. We are going to see over 18 million cases of malaria, which absolutely devastates economies and kills. And we're starting to see malaria in this country, by the way, with changes in weather patterns and things. So we're going to see a rise of malaria that is going to be an issue. And you're going to see a massive rise in NCDs, which is the unspoken pandemic. that is cost the U.S., for example, $2 trillion a year just to manage. And if we start pulling back on all of these fundings and not, we're going to start to see the rise of these and a real cost to the global economy as well as to the U.S.
Yeah, so one of President Trump's first moves was to sign an executive order beginning the process of withdrawing from the WHO. What was your reaction to that?
So, my reaction on that is one of fear for the destabilization for a global system that really does rely on global cooperation. Diseases do not respect borders. We learned that lesson incredibly well. We've just marked the 5th anniversary of COVID, and we saw what a global pandemic can do. It not only killed millions, but it devastated the global economy to the tune of trillions of dollars. And there are many communities, businesses that are still trying to recover from that moment. And we have a 50% chance of another COVID scale pandemic in the next 25 years. That is a very true and real threat based in science. And so when you look at that, our ability to have surveillance globally, our ability to mount defense when you see an outbreak in the moment and to be able to try to shut that down effectively is reliant on global cooperation. And the WHO is a big support to being able to execute that. They also provide critical norms that actually allow for countries to understand how to respond, what medications to use well. They provide the ability to pre-approved medications and other access. They provide very critical response information and framework that are on the leading edge of many of our health responses. So the WHO is actually a very important agent in the globe's security and well-being. And I think that as we need to start to understand health actually as a first line of our security, our human security. Because when you're sick, you're less likely to be able to earn income. As a business, you see the productivity go down because your workforce is sick. There's absenteeism. And there is, and people aren't able to show up and be productive. And there's really real studies that show the health of your workforce actually relates to your bottom line much better. And we know that it's a global security issue as well. And so the WHO actually is an agent of security for this globe in a way that I think that we don't fully recognize. And we're about to see, I think, a series of negative effects that are going to come from our failure to fund it.
So it sounds important to you that the U.S. remain within the WHO. Trump has suggested that he might be open to negotiating changes within the WHO to, consider staying in it. Do you think the WHO should engage in that? And is there any trade-offs that you think that would be beneficial?
So I think the WHO actually has been very responsive to the request for reforms. They've implemented over 70 of 80-something reforms that were requested of the WHO. They're dedicated to building themselves to be more efficient, more lean, and to really being in service to this world. And I am not an employee of the WHO, though I serve as a special envoy. I'm not an employee. So, I think that they've been very clear that they're very interested in engaging and really working with all partners, including the United States. I know there's been a critique that the U.S. disproportionately funds the WHO. The U.S. has been a very critical leader in global health funding and has been an important contributor. And I think that if we step away from our engagement globally on this health front, and we're going to cede our leadership. And we're going to see a rise of programs like China's Belt and Road and other countries fill that authority. There's a really strong soft power that comes from this global engagement and leadership. And to walk away from that is not going to make this country safer, more secure, or more prosperous, as is the goals. And so if we're really looking at that as our goals, we have to see health as a critical underpinning of our security, a critical underpinning of economic growth, security, and resilience, and a critical investment in, frankly, our sort of role in the world and how we're viewed.
Yeah, so switching gears a little bit to climate change. So how are we already seeing the impacts of climate change on public health, and why should we think of the two kind of together as, climate change as a public health crisis?
So human health is very much affected by the environment we live in. And as we see changes in extreme weather or changes in extreme heat, we know that workers, for example, that are exposed to extreme heat are more predisposed to having cardiovascular events, stroke, kidney issues, exacerbations of diabetes, chronic diseases that are very taxing or difficult to manage. We know that the quality of air can lead to worsened numbers of asthma attacks and can be very problematic. And so there's very deep links to our environment and human health. And changes in patterns of weather, extreme heat, or in our climate are not new phenomenon, if you will, but they exacerbate existing problems that we see in health. And so we do need to take into account the fact that human health is driven by the world that we live in and the environments that we're in, whether it's an urban city and buses going by that lead to asthma attacks, or the quality of the air, or whether we're being exposed to more extreme heat without some of the measures we need to protect. So there's an opportunity, I think, to really protect our workforce and our communities if we start to get educated on the ways that actually we very much are impacted by the world that we live in.
Yeah, so with the U.S. moving away from global health and climate change, funding that, in Europe, kind of very focused on defense spending right now, is there a crisis of financing resilience to health systems against climate change?
So there is without question a fiscal austerity. The whole pie has shrunk for many issues globally that we need to be addressing that require global collaboration or engagement, or for problems that don't respect disease borders, whether it is and our ability to mount, to invest in strong health systems. And I'm a health workforce person. Seed Global Health has trained over 47,000 healthcare workers in sub-Saharan Africa that are in service to 76 million people, really with the goal to build resilient, strong health systems that are responsive. We are looking at a clawback of investments that we started on strong health systems, which are our front line of defense, period, for all diseases. So strong health systems are pandemic preparedness. They are our efforts against non-communicable disease. They are our response to the extreme weather events and the health effects that we're seeing from heat or from climate. They are our response to protecting mothers' lives, battling the malnutrition that's going to affect 1 million people now with the funding, the children, with the funding cuts we're seeing. So I think that we are seeing a fiscal austerity, and we need to be very strategic about how we can actually mount a stronger response. But cutting off aid is not the answer. We are only going to find ourselves paying more in response than we would if we were protective and preventive in the front run.
Okay, I think that's all the time we have, but thank you so much for joining us, Dr. Carey. And next up, we're going to hear from my colleague, Carmen Pon, and she's going to speak with Dr. Atul Gawande. So thank you.
Thank you.
Hello, everyone. Thank you so much for those of you who stuck with us through the end. This is the final session. You made it. Well, 15, 20 more minutes, but I promise you will be worth your time. I'm Carmen Pon. I'm a global health reporter at Politico, and I'm here today with Dr. Atul Gawande, who I know many of you know very well. Until January, Dr. Gawande said, Dr. Gawande had a job that he describes as the best job in medicine no one has ever heard of. He led global health programs at the U.S. Agency for International Development, which, as most of you know, basically doesn't exist anymore. Dr. Gawande was also a surgeon at Brigham and Women's Hospital and a professor at Harvard. And the way I got to know Dr. Gawande was through his writing. He wrote 4 New York Times bestselling books. I do admit that I only read one. It's called Being Mortal, and for me, it was one of the most inspiring books I ever read, and I widely recommend it to those of you who haven't gotten to it yet. Thank you so much, Dr. Gawande, for taking the time to speak to us today. We're going to talk a lot about what has happened with USAID in the last 2 months and the impact of that. And you, yesterday, in a shadow hearing in Congress, described what has happened as a surgery with a chainsaw. And you're a surgeon, so that means a lot. Paint a picture for us of what you are saying now.
Well,
you have to understand, this is an agency that on half of the budget of the Boston hospital system where I do surgery, reached hundreds of millions of people with programs in global health that did everything from kept 20 million people living with HIV alive and was controlling the global HIV pandemic, to eradicating polio, to driving maternal mortality rates down. It also was critical to our capacity globally to secure disease surveillance and response to protect Americans from diseases developing abroad. So you can understand why leading this group of people doing this work is one of the best jobs I've ever had, is the best job in medicine that I've ever had. But since the administration took over, it has bit by bit decimated the program. Last Friday, the final notice went out to all of the workers at USAID, terminating them, their termination notice, which will end their employment either in July 1 or September 1. The awards and programs that I just described, 86% of the awards have been terminated. The plan is to port the last remaining programs over, but even those have been kneecapped. For example, maternal and child health programs have been cut 92%. All preventive programs to prevent outbreaks and spread of HIV have been terminated for key populations. There is still some drug distribution going on, but it's half of the program that used to exist. So, I mean, I can go on down the list, but this is a catastrophe. They paused on January 24 the program as if you could just turn a light switch on or off. But you're stopping a plane in midair, you're firing the crew, and then you're expecting that catastrophe will not happen.
And what struck me about what you said yesterday to Democratic members of the Senate Foreign Relations Committee was that we cannot bring USAID back, which I know there are still people hoping that that will happen, but you call on them to save U.S. research. Obviously, we are in the middle of hearing about all these cuts at HHS. We were reporting about it a whole day yesterday. Do you think that U.S. research itself is at risk?
Yes. So first, to understand what I'm saying, DOGE worked out its playbook on USAID. It started with the purge of the top leadership, then purge of half the staff, and then finally complete purge of staffing. It meant termination of contracts, not one by one, but mass termination of contracts in entire fields, and then entire removals of what became 86% of all of the contracts there. And removal of building leases so that the buildings were terminated. And you're seeing that play out now across, this is worked out while affecting the lives of hundreds of millions abroad, and the indirect effects of disease coming to the United States and the benefits to the country of the relationships that we build around the world. Now it's extended to hundreds of millions of Americans here at home with the same processes happening at HHS. So at NIH, you've seen it in terminations of contracts in the hundreds of millions of dollars, now becoming billions of dollars, a total suspension of any new research awards. And then go to the FDA and the purge yesterday that removed entire sections of FDA, vital work, whether it's around vaccines, the Office of Tobacco Control, food safety work, and the cell and gene therapy work that FDA regulates, but also makes possible by getting faster to approved solutions for the country. So the research that turns into approvals of drugs and other treatments then becomes guidance from the CDC, which also has been gutted in major portions, and then turns into Medicare, Medicaid distribution in the United States and USAID helping bring the most life-saving solutions around the world. That whole ecosystem, university scientists, public health providers, the logistics systems, the data systems that all lie behind that, they are being gutted as we speak. And the U.S. led the world in innovation, led the world in solutions that have successfully almost doubled the human lifespan in the United States and in the world. And we are stepping back from that in ways that have immediate consequences and very long consequences for us as a country.
One of the things that I came across a lot every time I wrote a story saying, global health is being gutted, people are going to die, was reaction from many people saying, most of it online, but also in real life from a family member, was like, why are we spending billions of dollars to help people abroad when our own people here cannot afford healthcare in many situations? And someone was telling me, my deductible is $6,000. Why are we sending my taxpayers' money to help people abroad? What do you say to people who express this kind of concerns?
First of all, yeah, $6,000 deductible is outrageous. And one of the things we know from work abroad is that we see countries that are achieving U.S. life expectancy, working with them, that are solutions we should be bringing back and can be bringing back. We've worked now with countries. I found, we have 2,500 people across 65 countries in the world when I was working at USAID. Mm-hmm. And it's experiments around the world in how to deliver on healthcare. And we have several countries like Thailand, Costa Rica, graduated mostly from assistance, have become important growing trade partners, and are also showing solutions that, for example, in Thailand on $300 per person per year, they are now nearly matching U.S. life expectancy by having a universal primary care program that does not have deductibles. Guess what we should be bringing here as part of what we do? But second, we talked about the disease outbreaks and the reasons why we want to be stopping diseases abroad before they get here. During my time, we had notifications of thousands of outbreaks around the world. We responded with assistance to stop 21 serious outbreaks around the world that would have cost vastly more money to be back at home and disrupted their economy. And so that's incredibly important. Another reason it's really important to have these relationships and do this work is USAID is the civilian capacity for deploying foreign policy around the world. We have thousands of people in countries abroad. And, when I was there and Russia attacked Ukraine, it was our teams that then helped arrange a response that, Russia cut off the access of medicines to Ukraine. They put every hospital under cyber attack and locked down their systems. And USAID was the response that enabled shifting their entire electronic medical record system to the cloud, to where it could be cyber protected and keep those hospital systems going. Helped them rebuild a supply chain that could be supplied by 5,000 aid organizations and got 50% of the pharmacies open in a month, 80% in 2 months. And, by the way, also helping maintain energy infrastructure. Keeps the health system going, but also keeps the country going and being more economically successful. So around core goals we have in the world, for not only for health and achieving global goals, like this is the agency that eradicated smallpox, it is eradicating polio, and that matters for us. We're in a measles epidemic right now. Those funds got cut off, and we're already seeing surges of measles cases around the world landing in the U.S. There's so many reasons to be doing this work.
You've also said that America's global health work cannot be transactional. Yet, what is very clear is that the current administration and many members of Congress see it in a transactional way. I was talking to Representative Brian Mast a few weeks ago, and he obviously chairs the House Foreign Affairs Committee, and he was telling me, countries in Africa took us for granted that we will always pay for their HIV drugs. And then, in turn, their governments turn around and do business with China on rare earths and other critical materials. So how do you square that with, some people feeling in government and Congress feeling that sort of like this investment hasn't necessarily paid off for America in terms of foreign policy and influence and the soft power that they were seeking through it?
So let me say two things about that. Number one is the payoffs have been clear and celebrated by many of the people who now have suddenly turned on it, including Senator Rubio, who is one of the great champions of U.S. aid. Why? Because it was broadcasting, it was the source of funding for independent broadcasting into Cuba, because it was the way we had influence in Africa and Asia without having to put troops on the ground. It was the way that we had democratic influence in Eastern Europe and in Latin America. So the power and the influence has been paid off multiple-fold in many ways. A second payoff: the majority of our top 20 trade partners at one time received U.S. assistance. To go from being, like India, a famine country dependent on food aid, to becoming a country that's an agricultural exporter, including to us, and one of our important trade partners and a bulwark against China. That happened because of these investments. But further, I'll give one example in HIV. We need to be moving countries to self-reliance, and this is part of how we do it. An American company, Gilead, had the breakthrough of the year last year. Science Journal called it the single most important research finding of the last year, which was the finding that a drug that they developed called lenacapavir in a single injection can prevent or treat HIV for at least 6 months, and data is looking like it's a year with a single injection can stop the disease. That is the pathway to move countries from dependence on U.S. support for treatments to deploying a solution that could stop and end HIV as a major public health threat, can be deployed through primary health clinics instead of specialized health clinics, and, by the way, should be what we're doing through our programs in the U.S. Donald Trump, in his first term, had made the fight against HIV globally and in the U.S. a major centerpiece. Now, the purges that have happened in both organizations, USAID and CDC, has meant that the fight against HIV domestically and abroad and stopping the disease has been abandoned, has been gutted. And that is of enormous harm to the U.S., whether it's HIV, TB, measles, or the progress we make in strengthening our health systems at home and abroad. We're going to pay the price.
My last question to you, just looking a bit at the future, where do we go from here on global health? I was reading a story recently that Bill Gates apparently told the administration privately that he's not going to be able to come in and, put billions more to fill the gap that the United States is leaving. And obviously, we don't see any other billionaires, other countries stepping in any massive way. Like, what's the outlook?
The outlook is poor. There is critical opportunity to save certain organizations that will really matter. The World Health Organization is one of them, and it makes absolutely no sense for the United States to treat global health as something that we do not engage in cooperation around the world to address. Another one is the global alliance called Gavi for vaccine aid, for vaccine solutions. This is co-founded by the United States and the Gates Foundation. It lowers prices on the world's vaccines by doing large-scale purchasing for the world. It has increased the manufacturing capacity and resilience outside of China around the world. And as a result of that, it has enabled vaccination that 1 billion children around the world have received and saved 17 million lives. U.S. is threatening to pull out of Gavi, and that does enormous harm. It's one of our biggest and best investments. 75% of child deaths, child mortality, was reduced over the last 50 years. So child mortality was cut by 75% in the last 50 years. 40% of that comes from vaccines. 60% of the vaccine benefit came from one vaccine, which is measles vaccines. So stepping away from the measles response efforts at WHO, from advancing measles vaccination to children around the world, it just by itself will cost hundreds of thousands of lives, and it's already causing a rise in imports of measles at a time when we are having spread in the United States. And then we're not even mounting an effort to take this on here. 3 months ago, in the last administration, I, along with the counterparts in CDC and domestic agencies, FDA, NIH, would all be meeting on a weekly basis to stop the measles outbreak, working together to figure out how we're going to do this. That simply is not happening, either the global effort or the national effort. And this is immediately dangerous and of concern. So I'm afraid I don't have really positive news to say about where this goes. It gets worse unless we stop it.
I didn't want to end on that note, but I have to. Thank you so much for your time and for your insight. This brings us to the end of Politico's Healthcare Summit. Thank you so much for being here throughout the day and for joining us for this important discussions on the future of healthcare policy. Stay tuned for future Politico events and see you next time. Thank you so much. Thank you.